Okay, so good evening, all of you. Uh, am I audible and am I visible to all of you? Ankit, I don't know how many hours, but I think it will go up till 2 to 3 hours. There are around 30 slides which I have to cover with you. So let's see how much time does that take. And if you are, a little worried about your time management, then it's better that once the session ends, you watch this entire video on 1.5x speed because this video will be here till you give your NEET exam. Now, this session is important for NEET PG students, and also if you are an FMG aspirant, then also this, and you are going to write your June 2023 exam, then this is also important for you, right? Okay, now coming to the first thing, and that is NEET PG revision session May. The first question which I want to discuss with you is how to calculate EDDs, right? So this was a question which had come in your previous year exams. Calculate EDD of a female with LMP 27 December 2021. And this I generally take up in all my classes because all of you know that whenever you have to calculate EDD, you have to the first day of the last menstrual period, you have to add 9 months and 7 days. Now, most of the times, like we go for maths may if you add 9 months first and 7 months, 7 days later on, that doesn't make any difference. Or if you add 7 days first and you add 9 months later on, that also doesn't make any difference. But when you are calculating EDD, it is always preferable that you add 7 days first and then 9 months because in some cases it might make a difference, right? So you have to always add 7 days first and then you have to add 9 months. So to 27th of December, you have to add 7 days. 27 December May, when you are going to add 7 days, 28, 29, 30th, 31st, 1st, 2nd, 3rd. So you come to 3rd January. Up January May, 3rd January May, when you are going to add 9 months, you are going to come to 3rd of October. So over here, the EDD is going to be 3rd of October. Now, please remember that if I would have added 7 days later on, I would have added 9 months first and then 7 days, then the answer would have been slightly different. How? If I would have added 9 months to December, I would have come to September, right? So I would have been on 27th September. Up 27th September May, when you add 7 days, 28th September, 29th, 30th, 1st, 2nd, 3rd, 4th, then your answer would have been 4th of October, right? So please remember, always it is preferable to add 7 days first and then 9 months. But this rule doesn't apply to the month of Feb. So do not apply this rule to the month of Feb. If you are calculating EDD and the LMP is in the month of Feb, then add 9 months and 7 days. For example, I'm doing a example question with you. You all have to calculate EDD if LMP is 25th Feb 2021. Tell the EDD. Calculate the EDD if LMP is 25th Feb. Now, whenever LMP is in the month of Feb, add 9 months first and then add 7 days. So 25th Feb May, you are going to add 26, 27, 25th Feb May, you are going to add 9 months first. So Feb May, when you add 9 months, it comes to March, April, May, June, July, August, September, October, November, right? So you come to 25th of November. Up 25th November May, add 7 days. So 26, 27, 28, 29, 30th, 1st, 2nd. So that brings you to 2nd December. Why I am telling you to remember this for the month of Feb? Because in the month of Feb, if you would have added 7 days first, then your answer would have been different. Agar 25th Feb May, if you would have added 7 days first, then your answer would have been 26th Feb, 27th, 28th, 1st, 2nd, 3rd, 4th. Right, so 4th of March May, you would have added 9 months and you would have come to 4th of December. That is why, remember, always add 7 days first and then 9 months for all months except Feb. In the month of Feb, add 9 months first and then add 7 days. Yeah, so that's right. Don't apply this rule on Valentine's month. In Valentine month, add month first and then the days. Clear to all of you? Now, for calculating EDD in IVF cycles, remember this, that if it is a fresh cycle, the day of oocyte retrieval is the day of fertilization. And if you know the day of fertilization is always day 14. So you will have to add 266 days to get the EDD. So simply remember, if it is a fresh cycle, you have to add 266 days. If it is a frozen cycle, then in that case you have to see whether it is day 3 transfer or day 5 transfer. In day 3 transfer, you have to add 263 days. In day 5 transfer, you have to add 261 days. Why? Because day 3 transfer ka matlab hai you are transferring it on day 14 plus 3, that is day 17. Right? So all of you know that the period of pregnancy is 280 days. The duration of pregnancy is 280 days. So 17 May, I will have to add 263 to get 280 as the answer. Right? So if it is a day 3 transfer, you have to add 263. Mehraj, understand. Day 3 transfer का मतलब है you are transferring it on the 3rd day after fertilization. Fertilization happens on day 14. So if this is a 28-day cycle, this is first day, this is 28 day. On day 14 ovulation happens and on day 14 fertilization happen. Day 3 का मतलब होता है that you are transferring it on day 17 of the cycle. 3 days after fertilization, you are doing the embryo transfer. And you also know that the total duration of pregnancy is 280 days. Ab 17 days nikal chuke hain and 280 days are calculated from the first day of the LMP. So 280 को लाने के लिए 17 में how much you will have to add? You will have to add 263. That means to day 17, when you add 263, you will get the EDD. Right? Similarly, if it is a day 5 transfer, then you have to add 261 days. Now, please remember, in case of IVF cycles, they are going to ask you these formulas only. Most of the times, they do not expect you to calculate the EDD. If you are well versed with these formulas, and these formulas have been included for the very first time in Williams, so you have to remember this, that in IVF cycle, in a fresh cycle, the day of oocyte retrieval may you have to add 266 days. In frozen cycle, for a day 3 transfer, you have to add 263 days. For a day 5 transfer, you will have to add 261 days. Clear to all of you? Yes. Pankhuri, you can do that. What you are saying, that you can subtract 16 from the day of transfer and then you can calculate EDD. Right? Okay. But थोड़ा सा हिंदी में, if I start speaking in Hindi, फिर तुम लोग कहोगे मैम इंग्लिश में. Now, coming to obstetrical score, I am going to do an example of obstetrical score with you. But before that, I want to tell you that obstetrical score can be written in 3 ways. Obstetrical score can be written where one single number represents gravida and one single number represents parity. All of you know gravida is number of times a female has conceived and it includes present and past pregnancy. Parity is the number of past pregnancies which have gone beyond 28 weeks of pregnancy, that is beyond the period of viability. Remember, twins and triplets are taken as a result of single conception. Right? Okay. Then comes, there are certain cases जब आप hospitals में you are going to see कि gravida तो single number से लिखा है, but in parity there are two numbers written. Whenever there are two numbers written in parity, the first number represents parity, that is the number of past pregnancies, right? जितनी भी past pregnancies थी which have gone beyond the period of viability, that is parity. Remember, parity में कभी भी you are not going to include present pregnancy, right? अब if parity में there are two numbers written, अगर दो numbers are written in parity, if two numbers are written, then the second number represents the number of pregnancy losses which are happening at less than 20 weeks, right? Clear to all of you? So that is if two numbers are written in front of parity. Now sometimes what happens is that in front of parity, four numbers are written. Now if four numbers are written, then the first number represents the number of term pregnancies, the previous number of pregnancies which have gone beyond 37 weeks. Second number represents number of preterm pregnancies. Preterm pregnancies का मतलब है the number of pregnancies which have gone between 20 to 36 weeks plus 6 days. Third number represents number of abortions. That is the number of pregnancies less than 20 weeks, and the last number represents number of living children at present. इसको कहते हैं GT-PAL system. The GT-PAL system is very important. GT-PAL system may for your exams remember that P over here is not parity. P over here is preterm pregnancies. And whenever you are telling the number of living children, right? So twins will be counted as 2. Triplets will be counted as 3. This is the only place where twins will be counted as 2 and triplets will be counted as 3. Clear to all of you? So now do this question for me. A 28-year-old pregnant female at 30 weeks of pregnancy comes for the first antenatal visit. Her obstetrical history is significant for a son who is 5 years old, who is now 5 years old and was born at 38 weeks. There is history of stillbirth 3 years ago at 30 weeks. Twin daughters who were born at 32 weeks 2 years ago, and one ectopic pregnancy. Her obstetrical score is. So this will be her 5th pregnancy. This is her 5th pregnancy, right? One son, then one preterm. The daughters were preterm, twin pregnancy, one ectopic pregnancy, one stillbirth, and presently she is pregnant, right? Ab batao, she is G5. Now tell me her GT-PAL score. Tell me her GT-PAL score. So G5, अब GT-PAL score के लिए, so that means now her score will be, the first is T, number of term pregnancies. पिछली कितनी pregnancies थी which have gone beyond 37 weeks. So there is only one pregnancy which had gone beyond 37 weeks. So 1 plus T-PAL, P stands for number of preterm. तो previous कितनी pregnancies preterm हुई? एक twin pregnancy preterm हुई. Preterm means pregnancy between 20 weeks to 36 weeks plus 6 days. Clear? So over here twins will be taken as a result of single conception. Then comes A, abortion. Abortion means any pregnancy loss which is happening at less than 20 weeks. That includes molar pregnancy, that includes ectopic. So there is history of one ectopic. Acha, preterm it is 2, sorry. She has 2 preterms, because she also has history of stillbirth, राइट। तो एक प्री टर्म है जो 32 वीक्स पे, ट्विन डॉटर्स, एंड एक स्टिल बर्थ हुआ 30 वीक्स पे, दैट इज ऑल्सो प्री टर्म। देन अबॉर्शन। नाउ टेल द नंबर ऑफ लिविंग चिल्ड्रन। लिविंग चिल्ड्रन कितने हैं? लिविंग चिल्ड्रन, जस्ट नाउ शी हैज अ सन and she has two twin daughters. Living children में you have to calculate twins as 2 and triplets as 3, right? So एक son है and दो daughters हैं. So G5P1 plus 2 plus 1 plus 3. So 1 plus 2 plus 1 plus 3. So this is option A, right? Preterm will be यहाँ पे preterm is any, see, and normally also preterm is any pregnancy less than 37 weeks. अब यहाँ पे जो preterm की रेंज लेनी है, abortions लेना है हमें up till 20 weeks. तो 20 वीक्स के बियॉन्ड, सो 20 वीक्स से लेके 36 वीक्स प्लस 6 डेज तक यू हैव टू से दैट इट इज गोइंग टू बी प्रीटर्म, राइट? नाउ इफ it is given, so Yogender is asking, if it is given that the baby was born dead at 37 weeks, what should we take as parity? Now you tell me. अगर आप ग्रेविडा और पैरिटी केवल लिख रहे हो, right? So suppose there is a female who is now presently pregnant and she's saying she has history of a baby who was born dead at 37 weeks. So this is her second pregnancy, and previous pregnancy, one of the pregnancies has gone beyond period of viability. It dead hua, that is a different thing, but it has gone beyond the period of viability. So G2P0. Someone is asking me this question in chat box कि suppose there is a female जिसमें still birth हुआ at 37 weeks, how are you going to write it? So if it is still birth at 37 weeks and suppose this is her second pregnancy, so now you tell me, gravida to will be, this is her second pregnancy, gravida will be 2. And parity is any number of pregnancies which have gone beyond the period of viability. So 37 weeks पे अगर still birth हुआ, so at least that pregnancy has gone beyond the period of viability. 37, ठीक है, just now the baby is not alive, but it has gone beyond the period of viability. So it is going to be G2P1, right? Now suppose हमें लिखना हो GT-PAL system में same thing, that there is a female who is, this is her second pregnancy, first pregnancy was stillbirth which happened at 37 weeks. अब कैसे लिखोगे? So this is her second pregnancy. 37 weeks का मतलब है the pregnancy had gone beyond term, right? 37 weeks. Preterm 0, abortions 0, number of living children 0. इसमें ना समझ आने वाला, यू जस्ट टेल मी दिस, पैरिटी का मतलब क्या होता है? पैरिटी का मतलब है प्रेगनेंसीज विच हैव गॉन बियॉन्ड द पीरियड ऑफ वायबिलिटी, दैट इज 28 वीक्स. तो अगर स्टिल बर्थ हुआ है एट 37 वीक्स, तो ऑब्वियसली प्रेगनेंसी हैज क्रॉस्ड 28 वीक्स, दैट इज व्हाई स्टिल बर्थ हैज हैपेंड एट 37 वीक्स. तो उसको तो पैरिटी में काउंट करोगे, हाँ, नंबर ऑफ लिविंग चिल्ड्रन में उसको काउंट नहीं करोगे, राइट? ओके, नाउ नेक्स्ट क्वेश्चन. So this GT-PAL system and 3 ways of writing gravida and parity. This is first way, this is second way, and this is third way of writing gravida and parity, right? Now come to the next question. Post-term pregnancy is associated with all except. So post-term pregnancy is associated with all except option A, macrosomia, option B, variable deceleration on CTG, option C, meconium, meconium aspiration, option D, transient tachypnea of newborn. समरीन, एक टॉपिक अबॉर्शन में आएगा, दैट इज व्हाई अबॉर्शन में हमने अभी यहां पे इस क्वेश्चन में क्योंकि ectopic की हिस्ट्री थी, here there was history of ectopic, that is why हमने यहां 1 लिखा था, राइट. सो ectopic तो आएगा अबॉर्शन में लेस देन 20 वीक्स पे if pregnancy loss is happening, whether it is ectopic, whether it is molar pregnancy, whether it is abortion, it has to be included in abortions only, right? Now remember, post-term pregnancy mein, what are the problems which are happening? Number 1, macrosomia. Yes, right. So any pregnancy which is continuing more than equal to 42 weeks, that's a post-term pregnancy. So baby is going to gain more weight. There is going to be macrosomia, right? Then number 2, there is going to be oligohydramnios. All of you know that maximum amniotic fluid is seen between 32 to, so my pen is not working. Okay. Maximum amniotic fluid is seen between 32 to 34 weeks, and as pregnancy continues beyond 40 weeks, the amniotic fluid decreases drastically. So, kyunki oligohydramnios, because there is going to be oligohydramnios, what is going to happen? Because of oligohydramnios, the space will be less, so there will be cord compression. Right? And all of you know that whenever there is cord compression, what happens on CTG? On CTG, you get variable decelerations. Right? So there is going to be variable deceleration. Then because of cord compression, there will be fetal distress. Now when there will be fetal distress, fetus is going to pass meconium into the amniotic fluid. So there will be meconium in amniotic fluid. And we all know that fetus swallows amniotic fluid also. So this meconium stained amniotic fluid fetus is going to swallow. So there is going to be meconium aspiration. Right? But what you don't get is transient tachypnea of newborn. So you don't get transient tachypnea of newborn. Next important thing. Now the third problem which happens whenever there is post-term pregnancy, the third problem is that there is placental aging. Now because of placental aging, there is uteroplacental insufficiency. And whenever there is uteroplacental insufficiency, CTG pe you get late decelerations. This means that both variable and late decelerations are seen in CTG in a post-term patient. So you can get both late decelerations and variable decelerations, but the more characteristic ones are variable decelerations. ACOG recommends that in all pregnant females who are more than equal to 41 weeks, pregnancy should be terminated. That's very, very important. We do not take pregnancy up till 42 weeks. We have to do induction of labor at 41 weeks. Clear to all of you? Next important question which they can ask you on post-term pregnancy is, which congenital malformation can lead to post-term pregnancy? So it is anencephaly which can lead to post-term pregnancy. Right? So it is taken as post-term. If you people stop writing comments, I am getting my mind is going there to what you are writing. You have still not come out of the GT-PAL score. Kusum, what has happened, ma'am? Twin babies resulted from single preterm pregnancy. Then why can't we take it as P1 in GT-PAL? We are taking it as P1. हमने कब P1 नहीं लिया twins को? Only place where we are taking twins as 2 is number of living children. Right? That is the only place where we are taking twins as 2. Otherwise, every other place we are taking twins as a result of single conception. Right? Okay. Now, a next very important question. What is the color of amniotic fluid in post-term pregnancy? The color of amniotic fluid in post-term pregnancy is greenish yellow color, right? Or saffron color amniotic fluid. Clear to all of you? Okay. I also want all of you to tell me, what do you understand by a term pregnancy? Term pregnancy means any pregnancy which is between 37 weeks to 41 weeks plus 6 days. Right? Preterm means any pregnancy which is less than 37 weeks. Right? Now, and post-term means any pregnancy which is beyond 42 weeks. Now, term pregnancy can further be divided as term. It is early term pregnancy, full term and late term. Early term, full term and late term. Early term pregnancy means any pregnancy between 37 weeks to 38 weeks plus 6 days. Full term means any pregnancy between 39 weeks to 40 weeks plus 6 days. And late term means any pregnancy between 41 weeks to 41 weeks plus 6 days. Right? So there is a lot of difference between early term and preterm. And there is a lot of difference between late term and post term. Late term is 41 weeks to 41 weeks plus 6 days. Post term is more than equal to 42 weeks. Clear to all of you? Yes. Now, coming to preterm labor, there was this question which I've already discussed with you in PYQs. Which of the following is not a diagnostic criteria for preterm labor? Now, please remember that according to ACOG, the latest definitions for preterm labor is regular uterine contractions which are happening at 37 weeks of gestation with regular dilatation and effacement of cervix, with progressive dilatation and effacement of cervix. Number one. Number two, any pregnant female who's coming to you at more than equal to 37 weeks and is having regular uterine contractions, and at the time of presentation she is already dilated to more than equal to 2 centimeters. Right? So, अब जो new definitions आई हैं, now the new definition for preterm labor is either a female coming to you with regular uterine contractions and having progressive dilatation and effacement, or if she's coming to you with regular uterine contractions at less than 37 weeks and at the time of presentation the initial dilatation is more than equal to 2 centimeters. Right? Now, the conventional definition for preterm labor was, what was the conventional definition, bachcho? It is if a female is having uterine contractions, and how many contractions? More than equal to 4 contractions in 20 minutes and more than equal to 8 contractions in 60 minutes. And along with these contractions, if the dilatation of the cervix is more than 3 centimeters. So now can you see the difference? New definition में they are saying dilatation more than equal to 2 centimeters. And new definition में they haven't told how many contractions. जो conventional पुरानी definition थी, they were telling that if the number of contractions were more than equal to 4 in 20 minutes or more than equal to 8 in 60 minutes, and along with that, one of the three which I'm going to tell you. Dilatation more than equal to 3 centimeters, length of the cervix less than equal to 2 centimeters, or if fetal fibronectin protein is present in cervicovaginal swab. And how much? More than equal to 50 nanograms per ml. Right? Now, अब ये जो question आया था, this question came in INI set. And in this question, you had to know the new definition also and you had to know the old definition also. Then only you would be able to solve this question. So let's see this question. Which of the following is not a diagnostic criteria for preterm labor? Option A, contractions, 4 contractions in 20 minutes or 8 contractions in 60 minutes. That is an old criteria. So yes, it is a definition for preterm labor. Then dilatation more than 1 centimeter. पुराना कहता है 3 centimeter, नया कहता है 2 centimeter. Right? So 1 centimeter तो कोई भी नहीं कह रहा. So I'm just keeping it in plus minus. Then more than 80% cervical effacement. So नई definition कहती है progressive dilatation and effacement. So yes, more than 80% effacement आ गया. Posterior cervix? No. Now, as far as dilatation 1 centimeter is concerned, now I have to choose between option B and D. अब B and D में से which one am I going to include in the criteria for preterm labor? I will include B in the criteria for preterm labor. Why? क्योंकि नई definition ये कहती है कि if there are regular uterine contractions and there is progressive dilatation. So suppose patient अभी 1 centimeter dilated है, maybe after some time she becomes 2 centimeter and she becomes 3 centimeters. Right, progressive dilatation हो जाए. Right, so although I would have preferred कि यहाँ पे more than 1 की जगह if they would have written more than 2, but because they have not written more than 2 and they have written more than 1, and the next option is posterior cervix, and if I have to choose between the two, which one should be included in preterm labor, I will include this option B in preterm labor, and my answer will be option D. Posterior cervix is never included in the definition or the diagnostic criteria for preterm labor. Clear to all of you? Now comes the question that which one are you going to remember? You are going to remember both of them. Because if a question like this comes, you have to know the conventional definition also, and you have to know the new definition as well. Right? But which one are you going to follow? It has to be the new definition which you have to follow. But जानना हमें दोनों definitions हैं. Right? Now, next very important question in preterm labor is always the management of preterm labor. अब preterm labor में हम preterm labor को early preterm labor and late preterm labor में divide करते हैं. Early preterm labor का मतलब है if preterm labor is happening at less than 34 weeks. Late preterm labor का मतलब है if it is happening between 34 weeks to 36 weeks plus 6 days. Right? Ab I am going to tell you a very easy chart by which you can remember the management of preterm labor. Remember, कोई भी किसी भी type का preterm labor हो, induction of labor is never done. Right? कभी भी induction of labor is never going to be done. Exact 37 है तो preterm कैसे होगा बेटा? तभी तो I am writing 36 weeks to 36 weeks plus 6 days. 37 weeks का मतलब है it is term. Right? Okay. So induction of labor चाहे वो early preterm हो चाहे वो late preterm हो, you never do. Then whether it is early preterm or whether it is late preterm, in both the cases you have to give corticosteroids so that the lungs of the baby mature. Then in case of early preterm labor, along with corticosteroids, you have to give tocolytics. Please remember, kabhi bhi tocolytics are never given beyond 34 weeks. So you never give tocolytics beyond 34 weeks. So in case of late preterm labor, you are not going to give tocolytics. In case of early preterm labor, you will give tocolytics. Then comes magnesium sulfate. What is the role of magnesium sulfate in preterm labor? Magnesium sulfate prevents cerebral palsy in the fetus. Right? It is for neuroprotection. And it is believed that the baby's nervous system is fully mature by 32 weeks. So, agar preterm labor is happening at less than 32 weeks, then you have to give magnesium sulfate for neuroprotection. So, in case of early preterm labor, agar early preterm labor is happening at less than 32 weeks, you are going to give magnesium sulfate. But in case of late preterm labor, you never give magnesium sulfate. What is the role of tocolytics in preterm labor? The only role of tocolytics is they buy time for corticosteroids to act. Corticosteroid को 48 hours चाहिए होते हैं to act, and उस 48 hours तक so that a patient doesn't deliver, we give tocolytics. Now, it is believed that the lungs of the baby start maturing by 34 weeks. So, if it is a late preterm labor, I will give corticosteroids, but I will not give any tocolytics. Because by chance, agar delivery ho bhi gayi, even after the first dose of corticosteroids, that's okay. Right? But in case of early preterm labor, that means preterm labor which is happening at less than 34 weeks, I want the lungs to be mature before the patient goes into labor, and that is why I will give full time for the corticosteroids to act. So I am going to give tocolytic. Now, when we talk, the last thing is, I will talk about tocolytics a little more, but over here first remember what I'm telling you. Then comes GBS prophylaxis or GBS screening. Now, in both these cases, whether it is early preterm labor or whether it is late preterm labor, either you have to go for GBS screening, that means you have to take out a rectovaginal swab for GBS screening, or you give GBS prophylaxis. It has to be done in both the cases. अगर आपको लग रहा है कि टाइम है तो आप स्क्रीनिंग कर लो, रेक्टोवेजाइनल स्वॉब लो एंड भेज दो जीबीएस टेस्टिंग के लिए, एंड इफ द यू नो दैट द पेशेंट विल नॉट डिलीवर, सो यू वेट फॉर द रिजल्ट. अगर रिजल्ट पॉजिटिव आए तो तब दो जीबीएस प्रोफाइलैक्सिस. बट इफ यू फील यू डोंट हैव टाइम, देन रादर देन गिविंग अ स्वॉब एंड पीछे से पेशेंट डिलीवर कर जाए, उससे बेटर है गो फॉर जीबीएस प्रोफाइलैक्सिस. Right? But GBS prophylaxis or GBS screening should be done in both the cases, whether it is early preterm labor or whether it is late preterm labor. So whenever you get a question on preterm labor, look at the gestational age at what preterm labor is happening, and then remember this table, and according to this table, manage your patient. Clear to all of you? Okay. So this is something which I told you just now. What is early preterm, early term, full term, late term, preterm and post term. All this I have told you just now. Now tocolytic. When we are talking about tocolytic, this I told you in the last session also, that in India the tocolytic of choice is nifedipine. According to ACOG, up till 32 weeks, it is indomethacin. Between 32 to 34 weeks, it is nifedipine. Right? And tocolytics are never given beyond 34 weeks. Clear? अब आते हैं corticosteroids पे. Corticosteroids पे, this was a very important question which had come to you, because dose of corticosteroid is very, very important. So tell me, what is the dose of dexamethasone given for fetal lung maturity? What is the dose given for fetal lung maturity? So please remember, doses of dexamethasone and doses of betamethasone are very important for you. Dose of betamethasone is, you have to give 2 injections, 12 mg each, 24 hours apart. Dose of dexamethasone is, you have to give 4 injections, 6 mg each, 12 hours apart. Right? Both these have to be given intramuscularly. So whichever you are choosing. In India, we choose dexamethasone and it has to be given intramuscularly. Worldwide, the corticosteroid of choice is betamethasone. The only contraindication for giving corticosteroids is chorioamnionitis. Now, whenever you are doing lung maturity test and they ask you which is the best lung maturity test, please remember that the best lung maturity test is presence of phosphatidylglycerol in amniotic fluid. Right? Phosphatidylglycerol in amniotic fluid. If phosphatidylglycerol is present in amniotic fluid, then that means lungs of the baby are mature. If it is not present, then it means lungs of the baby are not mature. This question they are going to ask you like this. They are going to say that there is a diabetic female, in a diabetic female, which is the best lung maturity to test to know whether the baby's lungs are mature or not. So why is it they ask this question in context of diabetic females? This is because diabetic females may, because of increased insulin, the insulin has a decreased or it inhibits the release of surfactant. क्योंकि insulin ज़्यादा होता है in diabetic patients, this insulin decreases the release of surfactant, and that is why in diabetic patients there are increased chances of respiratory distress syndrome in the baby. Now, whether they ask you, diabetic female, or whether they ask you non-diabetic female, right? Whether it is diabetic or whether it is non-diabetic, always the best lung maturity test is phosphatidylglycerol in amniotic fluid. Clear to all of you? Yes? Okay. Coming to the next question. Very, very important question, where you have to arrange the following investigations in increasing order of gestational age at which they are performed. So tell me, A पहले होगा या B पहले होगा या C पहले होगा या D? In increasing order of gestational age. Arrange it and tell me. So number 1 is screening of diabetes, then maternal serum alpha fetoprotein, then nuchal translucency and ultrasound for confirmation of placenta previa. So arrange it in increasing order of gestational age in which you have to perform. So tell me, screening of diabetes कौन सी age में करते हैं? Screening of diabetes, it is done in the first antenatal visit and then between 24 to 28 weeks. Maternal serum alpha fetoprotein कब करते हैं? It is done between 15 to 20 weeks. Nuchal translucency scan, when do you do it? Between 11 to 13 weeks plus 6 days, that is approximately 11 to 14 weeks. Ultrasound for confirmation of placenta previa, this is done in third trimester around 32 weeks. Right? So, my pen has stopped working. 32 weeks. So now the order is going to be A, right? So you are going to first do A, then you are going to do C, then you are going to do B, and then you are going to do D. Clear to all of you? Yes? So A, C, B and D, that is the increasing order of gestational age at which these investigations are done. Very good, Austin. A, C, B and D. Clear? Okay. Now, remember, there are certain names given to ultrasounds which are performed at specific times. So, dating scan or a viability scan, that's the first ultrasound which you do, which is done between 6 to 8 weeks. Nuchal translucency scan is done between 11 weeks to 13 weeks plus 6 days. Anomaly target scan or booking scan, this is level 2 scan which is done in all pregnant females between 18 to 20 weeks. Growth scan is done between 30 to 32 weeks. And just in case echo is needed, anytime if fetal echo is needed, it is done between 22 to 24 weeks. Right? Now, other than that, remember, maternal serum alpha fetoprotein levels, whenever you have to check, you check them between 15 to 20 weeks. Chorionic villi sampling, you do it at any time beyond 10 weeks. Ideally, you should do it between 11 to 13 weeks. Amniocentesis is done again between 15 to 20 weeks. Best time is 16 to 18 weeks. Right? Then group B streptococci screening. Group B streptococci screening, this has to be done in all pregnant females by taking out a rectovaginal swab, and this is done between 36 to 37 weeks. Right? So these are all investigations and their respective timings at which you have to do them. Clear to all of you? Yes? So questions, they are going to ask you, make different combinations and permutations of these questions, and then they are going to ask you this. Clear to all of you? Now, I want to just tell you, suppose they ask you in entire pregnancy, you have to do one ultrasound. Then that ultrasound should be target scan or anomaly scan or booking scan, which has to be done between 18 to 20 weeks, right? Now, ultrasound for placenta previa. Ultrasound for placenta previa, it has to be done in third trimester. You do it at 32 weeks followed by 36 weeks. Please remember, whenever a patient of antepartum hemorrhage comes to you, right? Now, when a patient of antepartum hemorrhage comes to you and the first investigation you have to do, then the first investigation which you are going to do will be a transabdominal scan. In a transabdominal scan, if you see that the placenta is located in the lower segment, then the investigation of choice for placenta previa is TVS. And this TVS has to be done at 32 weeks and it has to be done at 36 weeks, right? Then the other thing, in all high risk pregnancies, you have to start antepartum fetal monitoring. And this antepartum fetal surveillance is started from 32 weeks, right? And in antepartum fetal surveillance, we are going to include NST, we are going to include biophysical score, right? And this has to be done either weekly. So in all high risk pregnancies, you do it either weekly, or in certain cases, you might have to do it twice weekly, or you might even have to do it daily. Clear to all of you? Then in case of RH negative pregnancy, indirect comb test. Indirect comb test is done at the first antenatal visit and then you repeat it at 28 weeks, right? In case of PIH, if you have to predict PIH, then a uterine artery Doppler, it has to be done between 22 to 24 weeks, right? And this, these days there is a trend for early uterine artery Doppler. Early uterine artery Doppler is done between 11 to 13 weeks, right? And this early uterine Doppler is going to detect early onset preeclampsia. Clear? Then comes your about twins. In twins, when are you going to do ultrasound? Because in twins, the investigation of choice to detect chorionicity is ultrasound. So when are you going to do this ultrasound to find the chorionicity? The best time to do ultrasound to detect chorionicity is 10 to 14 weeks, right? Now, just now I told you that chorionic villi sampling is always done beyond 10 weeks. Ideally, it is done between 11 to 13 weeks. So, you are going to tell me what is the most common complication of chorionic villi sampling. What is the most common complication of chorionic villi sampling? If they ask you this question, that what is the most common complication of chorionic villi sampling, your answer will be fetal loss. But if they ask you what is the most common complication of chorionic villi sampling, which is done at less than 10 weeks, then the answer is oromandibular defects or limb defects. Oromandibular defects or limb defects. That is why chorionic villi sampling is never done at less than 10 weeks. Clear? So this is for all the investigations which you are doing in pregnancy. Now, please remember, fetal echo, which I told you over here, it is done between 22 to 24 weeks and only if it is needed. If you are suspecting a cardiac problem in the fetus, or if mother is a case of overt diabetes, In overt diabetes, we know that the congenital malformations the most common congenital malformations are cardiac malformations. That is why in case of overt diabetes, I am going to do fetal echo. But otherwise, in all cases, fetal echo is not required. If fetal echo is required, it is done between 22 to 24 weeks. Clear to all of you? All the investigations list clear? Okay. Now, as advised by the government of India, what are the antenatal visits? So, in antenatal visits, the minimum number of antenatal visits which have been advised by government of India are 4. According to WHO, they are 8, and ideally they should be 12 to 15. Now, what is the caloric requirement? According to PARC, as I told you, in all trimesters, you can give 350 kilocalories per day. According to our national guidelines, in first trimester, very small amount is needed, roughly 85 kilocalories, or no additional kilocalories is also fine. In second trimester, roughly 300 kilocalories, and in third trimester, roughly 400 kilocalories per day. Additional. This is additional kilocalories which are needed. Right? Then they may ask you a question on RDA, that is routine daily allowance. So routine daily allowance may you have to remember what is the routine daily allowance of iodine in pregnancy. The routine daily allowance of iodine in pregnancy is 250 micrograms per day. Routine daily allowance of calcium in pregnancy is 1000 milligrams per day, and routine daily allowance of carbohydrates in pregnancy is 175 grams per day. All this is very, very important. Right? Then the amount of protein which is needed in a non-pregnant female is 45 grams per day. In first trimester, no additional protein requirement. In second trimester, additional 10 grams of protein, and in third trimester, additional 20 grams of protein is needed. Right? Then the requirement of fat in pregnancy is 28. Normally it is 28 grams per day which you have to give. That is the requirement of fat in a pregnant female. Now over here I told you this is what our national guidelines say. Our national guidelines say that in the first trimester 85 kilocalories, in second trimester 300 kilocalories, and in third trimester 450 kilocalories. I also want you to remember what has been advised by ACOG and Indian Institute of Medicine. Indian Institute of Medicine. Indian Institute of Medicine says that in first trimester no additional kilocalories. So this is 0 kilocalories ka matlab no additional kilocalories. In second trimester 350 additional kilocalories, and in third trimester 450 additional kilocalories. This is what Indian Institute of Medicine says. So is this clear to all of you? Okay. Then comes, so these are all the things which you need to know about OBS, where all those PSM things which you need to know in OBS. Right? Now comes folic acid supplementation. Now folic acid supplementation, that's again very important to prevent neural tube defect. 400 micrograms per day. This 400 micrograms per day should be given 1 month before conception, and it should be continued for 3 months after conception. To prevent the recurrence of neural tube defect, 4 milligrams per day. Recurrence ka matlab hai patient already has one baby with neural tube defect. Right? And this should be given 3 months before pregnancy and continued for 3 months after pregnancy. But please remember that we are gynecologists and obstetricians. We are not astrologers. So since we are not astrologers, That is why I cannot say that now after 3 months you are going to become pregnant. So we say that whenever a female comes to me and she has previous history of baby with neural tube defect, then whenever she's planning pregnancy, then I'm going to start her on folic acid. So a better answer will be that whenever the patient comes prenatally, I will put her on 4 milligrams of folic acid. Then to treat folic acid deficiency, the dose of folic acid which is needed is 1 milligrams per day. In diabetic patients, again, it is 400 micrograms per day. In patients on anti-epileptics, it is 4 milligrams per day. And to treat sickle cell anemia, it is 5 milligrams per day. Right? Now, then comes vaccines in pregnancy. The vaccines which are safe in pregnancy, please remember they are hepatitis A, hepatitis B, influenza vaccine, rabies vaccine, pneumococcus, meningococcus and COVID-19 vaccines. Now, vaccines which are contraindicated in pregnancy are all live vaccines. For examples, MMR, mumps, measles, rubella, right? Then BCG, smallpox, chickenpox and HPV. Now, someone is asking me, what to write if they don't specify ACOG guidelines or WHO guidelines. So if they are not specifying, always and always you should write ACOG guidelines. WHO की guidelines आप तभी दोगे when they ask you about WHO guidelines. And not all those places where our national guidelines are available, we prefer giving answer with respect to our national guidelines. Right? So जैसे diabetes में हमारी national guidelines हैं, तो I'm going to give answer as per our national guidelines. Right? Then what are those vaccines which can be given under special circumstances? That is, if a female is traveling to that area, and that area is endemic for that particular problem. So that is yellow fever, polio and typhoid vaccine. So this is a list of vaccines which are safe, the ones which are contraindicated and the ones which are given under special circumstances. Remember, TD vaccine is the one which you give normally in pregnancy if the female had received a complete tetanus course in any of the time in past 3 years. Then in this pregnancy, you only have to give her a booster. But if she did not receive any tetanus vaccine in previous 3 years, then you have to give TD vaccine at the initial antenatal visit and then you have to repeat a dose after 1 month. TD stands for tetanus and diphtheria toxoid, right? Now, weight gain in pregnancy. Normally, the weight gain which is recommended in pregnancy is 11 to 12.5 kgs. If the BMI of the patient is less, that means she's thin, then the recommended weight gain is 12.5 to 18 kgs. And if BMI is more than 30, that means she's obese, then the recommended weight gain is 7 kg, right? सोनू कुमार, कोविड वैक्सीन मोस्ट ऑफ द टाइम्स जब पेशेंट आपके पास आएगी शी विल बी फुली वैक्सीनेटेड अगेंस्ट कोविड, बट जस्ट इन केस आपकी प्रेग्नेंट पेशेंट को कोविड वैक्सीन नहीं लगा है, दैट एंड देन एट एनी टाइम ड्यूरिंग प्रेगनेंसी यू कैन गिव कोविड वैक्सीन. यू कैन गिव कोविड वैक्सीन even in the first trimester, right? Now coming to anemia in pregnancy. So look at this question. A G2P1 female at 30 weeks of gestation presents with fatigability, loss of appetite and lethargy. So all these are pointing towards anemia symptoms. On examination, pallor is present and on examination her hemoglobin is 6.5 grams. Right? Her vitals are stable and there are no signs of CHF. Nestrov test is negative. Mentzer's index is 15. Now, you tell me, what conclusion do you draw from this? What is Nestrov test for? Nestrov test is for thalassemia screening. तो Nestrov test negative का मतलब है, Nestrov test negative का मतलब है कि thalassemia नहीं है. Similarly, Mentzer index more than 15 means thalassemia नहीं है. It is a case of iron deficiency anemia. Right? तो सबसे पहले you should know that from your question, how are you going to differentiate between iron deficiency anemia and thalassemia and physiological anemia? So please remember, Most common anemia in pregnancy is physiological anemia. Physiological anemia is due to hemodilution. In physiological anemia, never will the hemoglobin be less than 11. Always hemoglobin will be more than 11. Right? And physiological anemia is normocytic normochromic anemia. Now, iron deficiency anemia and thalassemias are examples of pathological anemia. And in both of them, the hemoglobin is going to be less than equal to 11 gram percent. Right? Now, in both of them, the on peripheral blood smear, you are going to get microcytic hypochromic anemia. अब बहुत important होता है कि हम ये जाने कि हमारी पेशेंट को आयरन डेफिशिएंसी अनीमिया है या थैलेसीमिया, बिकॉज बोथ मैनेजमेंट इज डिफरेंट. आयरन डेफिशिएंसी अनीमिया में मैनेजमेंट इज आयरन. थैलेसीमिया में जो आयरन इज कॉन्ट्राइंडिकेटेड, ऑलरेडी बहुत आयरन ओवरलोड होता है इन थैलेसीमिया. सो इन थैलेसीमिया यू ऑलवेज हैव टू गिव ब्लड ट्रांसफ्यूजन. सो हाउ आर यू गोइंग टू नो फ्रॉम योर क्वेश्चन whether you are dealing with thalassemia or iron deficiency anemia? So there are three ways by which you are going to know from your question. Number one, red cell distribution width. Red cell distribution width is increased in iron deficiency anemia. It is normal in thalassemia. Number two, Nestrov test. Nestrov test will be negative in iron deficiency anemia. It will be positive in thalassemia. Number three, Mentzer's index. Mentzer's index will be more than 13 in iron deficiency anemia. It will be less than 13 in thalassemias. Right? So, remember, in iron deficiency anemia, management can be oral iron, parenteral iron, or blood transfusion. In case of thalassemia, management is only blood transfusion. Clear? So, in this question, I am dealing with iron deficiency anemia. And अब देखो hemoglobin कितना है. Hemoglobin is 6.5. And at what time has the patient presented to you? Patient has come to you at 30 weeks. Now you are going to follow this flow chart. Now, if it is severe anemia means hemoglobin less than 7, and your patient has severe anemia, she has hemoglobin 6.5. So, whenever there is severe anemia, you divide it into two categories. कि क्या hemoglobin less than 5 है या hemoglobin between 5 to 7 है. If hemoglobin is less than 5, then always you have to give blood transfusion irrespective of gestational age. But if hemoglobin is between 5 to 6.9, that is between 5 to 7, then you have to look at gestational age. If gestational age is more than 34 weeks, blood transfusion. If gestational age is less than 34 weeks, parenteral iron. Now, in case of mild to moderate anemia, that means any anemia which is lying between 7 to 11, you have to check the gestational age. If gestational age is less than 34 weeks, 2 tablets of iron and folic acid, right? 2 tablets. And if gestational age is more than 34 weeks, parenteral iron. Another thing which I want you to remember is whether you are giving parenteral iron or whether you are giving oral iron. In both these cases, you have to check her hemoglobin after 3 weeks. Ideally, we do it after 1 month because increase in hemoglobin is going to happen with both parenteral and oral iron after 3 weeks. Right? Clear to all of you? Yes. Anemia Mukt Bharat program is for preventing anemia, and Anemia Mukt Bharat program mein you have to give 1 iron folic acid tablet daily starting from 4th month and throughout pregnancy plus 180 days after delivery. To treat anemia, you have to give 2 tablets. So, yahan pe you are giving 2 tablets per day. Clear to all of you? And ये जो 2 tablets आप दोगे, ये 2 tablets you are going to give it up till her hemoglobin becomes 11. The day her hemoglobin becomes 11, now from 2 tablets, you will switch her to 1 tablet, and you will continue that 1 tablet throughout pregnancy plus 180 days after delivery. Clear to all of you? Yes? Okay. Also remember, this was about oral iron, what you had to remember. About parenteral iron, remember that parenteral iron is contraindicated in first trimester. Never are you going to, if your patient has anemia in first trimester, you can give her oral iron or you can give her blood transfusion. You can never give her parenteral iron. Now, if your question says, जैसे यहाँ पे questions ने कहा था vital stable. Now, if instead of stable vitals, your question would have said unstable vital. Unstable vital का मतलब है that it is happening because of blood loss. So, whenever your question says unstable vitals, then you don't have to think about anything else. Then your answer is going to be blood transfusion. Irrespective of कितना hemoglobin है, कितना gestational age है, unstable vitals अगर question में देखो, answer is blood transfusion. Similarly, अगर Nestrov test positive देखो, that means it is thalassemia, and that means again you are going to give blood transfusion. And agar signs of congestive heart failure positive dekho, that patient is having signs of congestive heart failure, again irrespective of gestational age, irrespective of hemoglobin, your answer is going to be blood transfusion. Clear? Yes. So this is how you treat anemia in pregnancy. So very, very important topic. Now someone was asking me what is the dose of IFA. I am not telling you the dose of IFA because in my PYQ session I have dealt with IFA. Please remember, it is 60 milligrams of iron and 500 micrograms of folic acid. It is a red pill, right? Some important points which you need to know on MTP. No, I am not, see, the PYQ PDF I have made available for all of you. Now this PDF you are going to you are going to write it. I am not going to make this PDF available. Okay. Now coming to the next question, and that is, as per the revised rules of MTP Act, which of the following is or are required by a registered medical practitioner to qualify for performing MTP? Right? So what are the requirements for MTP? Requirements for a registered medical practitioner to be able to do MTP. Number one, they are saying having a degree or diploma in obs and gynae. Yes, degree or diploma in obs and gynae is necessary. They should have assisted in 15 MTPs. No, they should have assisted in 25 MTPs, in which 5 he or she should have been the primary surgeon. They should have done house training for 12 months in OBGY. No, house training for 6 months in OBGY. Right? Certified for 6 months in laparoscopic surgery? No, that's not a requirement at all. The requirements are either degree or diploma in obs and gynae. Then they should have assisted in at least 25 MTPs, in which in 5 he or she should have been the primary surgeon. Number 3, they should have done house training or house job in OBGY for 6 months. So यहाँ पे only one is correct, and only one correct means option D is the correct answer. Right? Clear? Now, the other things which you have to remember is, as per the new MTP Act, the MTP Amendment Act, MTP can be done now up till 24 weeks. But if pregnancy is a result of contraceptive failure, then in that case, MTP is done till 20 weeks. Right? Now, if there is gross severe congenital anomaly of the fetus, so in case of gross severe congenital anomaly of the fetus, there is no upper limit for performing MTP. Right? So please remember this. If they ask you till till when can MTP be done? It can be done till 24 weeks. Exception is if it is contraceptive failure, you do it up till 20 weeks. And in case of gross congenital anomalies, there is no upper limit for performing MTP. till 20 weeks, only one doctor's opinion is needed. Between 20 to 24 weeks, two doctors' opinion is needed. And if you want to see whether gross congenital anomalies are present or not, then there is a board, and this board consists of one gynecologist, one pediatrician, one radiologist, and one person who is assigned by the state. Right? So these are the four people who are going to decide whether the fetus has severe gross congenital anomalies or not. Clear? Then next question. All statements are true about the device shown in the image except. MTP amendment law is very, very important. So please remember that. All statements are true about the device shown in the image except. Option A, volume 60 ml. Option B, it can be used in outpatient setting. Option C, generates a pressure of 60 millimeters of mercury. Option D, it can be used up till 12 weeks. Now, remember that up till 7 weeks, जो best method होता है MTP का, that is medical abortion. Right? Up till 7 weeks, best is medical abortion. Medical abortion में, when you are doing medical abortion up till 7 weeks, then on day 1 you are going to give mifepristone 200 mg, and then you are going to wait for 24 to 48 hours, and on day 3 you are going to give misoprost 400 micrograms, which can be given sublingual, buccal, vaginal or oral. And if you are doing up MTP between 7 to 9 weeks, then again on day 1 you are going to give mifepristone, and on day 3 now you are going to give misoprost up till 800 micrograms. Now remember, in India, medical abortion is done only up till 7 weeks. India may we do it up till 7 weeks. WHO says you can do it up till 9 weeks. So if I'm doing medical abortion between 7 to 9 weeks, I have to follow this protocol. Right? Now, up till 7 weeks, best method is medical abortion. Between 7 to 12 weeks, best method is suction evacuation. Suction evacuation ko karne ke, there are two methods. One is the electrical suction evacuation. The other one is manual vacuum suction evacuation. अब इलेक्ट्रिकल सक्शन इवैक्यूएशन में जो कार्मन्स कैन्युला होता हुआ है, वी टेक अ प्लास्टिक कैन्युला विच इज कार्मन्स कैन्युला एंड दैट इज अटैच्ड टू अ सक्शन मशीन, and the size of the Carman's cannula, it should correspond to the period of gestation. ये जो electrical suction evacuation है, you can do it up till 16 weeks, and when you do it up till 16 weeks, it is called as dilatation and evacuation, right? And this means कि हम maximum जो cannula का size use कर सकते हैं for electrical suction evacuation, you can use a 16 mm cannula. So I am repeating. Suction evacuation can be done electrically, it can be done manually. Electrical suction evacuation जो है, you can do it up till 16 weeks. जब आप 12 वीक्स तक करते हो, उसको आप बोलते हो सक्शन इवैक्यूएशन. जब आप 12 वीक्स टू 16 वीक्स के बीच में करते हो, यू कॉल इट एज डायलिटेशन एंड इवैक्यूएशन. बट नेवरदलेस जो सक्शन इवैक्यूएशन है, यू कैन डू इट up till 16 weeks. That means suction evacuation can be done in first trimester MTP as well as for second trimester MTP. Right? Now, then comes manual suction evacuation. Manual suction evacuation you do with the help of this syringe, which is called as MVA syringe, manual vacuum aspiration syringe. इस syringe की the peculiar point about this syringe is that this has got two pinch valves. The pressure which is generated, this doesn't need any electricity, and the pressure which will be generated by this MVA syringe is 660 millimeters of mercury. If 660 is given in the option, you are going to mark 660 as the answer. But if 660 is not given, then the second best answer is going to be 600 millimeters of mercury. And the volume of this syringe is 60 ml. Right? Clear to all of you? Now, remember, ये जो manual suction evacuation है, which you are doing using MVA syringe, it can be done up till 12 weeks, राइट एंड इसका में जो आप मैक्सिमम कैनुला का साइज यूज कर सकते हो दैट इज 12 mm. एज आई टोल्ड यू द साइज ऑफ द कैनुला
I didn't catch that. Could you try again?
The size of the cannula depends upon corresponds to the period of gestation. So because electrical suction evacuation can be done up till 16 weeks, the maximum size cannula जो हम electrical suction evacuation में use कर सकते हैं that is 16 mm. And MVA syringe के साथ, so in this MVA syringe I am going to add a Carman's cannula. A plastic cannula will be attached to the front of this syringe. कोई suction machine नहीं चाहिए. You are going to attach this syringe to a Carman's cannula. And because this can be done only up till 12 weeks, तो maximum size जो हम Carman's cannula का use कर सकते हैं for MVA is for manual vacuum aspiration is 12 mm. Clear? Right? So remember about MVA syringe, remember about manual suction evacuation and electrical suction evacuation. Now, then a very important question which comes to you in your exams is you have to identify the type of abortion. Now, whenever they give you a question and you have to identify the type of abortion, the first thing which you have to see is whether the question is telling you about history of passage of any clot or not. Right? Now, if there is history of passage of clot present, history of passage of product of conception present, then in that case, either it is a case of incomplete abortion or it is a case of complete abortion. Complete abortion and incomplete abortion, in both these cases there is history of passage of product of conception. तो अब हमें देखना है क्वेश्चन में कि what have they told you about the os. If os is closed, that means it's a case of complete abortion. Right? And अगर os closed है, then os open है, then it is a case of incomplete abortion. Ma'am, please tell about second trimester abortion methods as well. Okay, so second trimester abortion methods, if you are asking me, second trimester abortion methods में, let me write. What has happened to my pencil today? Wait. Where can I write? It's not writing. So you write it yourself. My pencil, I don't know what has happened to it. Second trimester methods. In second trimester methods, the first method which you have to know is again dilatation and evacuation. Dilatation and evacuation. I told you can do it up till 16 weeks. Then number 2, you can go for prostaglandins. In prostaglandins, you can use mesoprost or you can use PGF 2-alpha. Number 3, you can use extra amniotic ethacridine. Extra amniotic ethacridine. This is an outdated method, but you can use it. Extra amniotic ethacridine. Number 4, you can give oxytocin. And number 5, if nothing works, then you can go for hysterotomy, not hysterectomy. You can go for hysterotomy. Clear to all of you? Yes. So these are your second trimester MTP methods. In second trimester, the best method for doing MTP is prostaglandins, right? And you are going to use mesoprost basically for second trimester MTP, right? Any other thing which you need to ask? Ma'am, can we get PDF? I am not in favor of giving you PDF. because otherwise you don't pay attention and you are just waiting for the PDF. Okay, someone is asking me about the dose of misoprost. So remember, the dose of misoprost can range between 200 to 800 micrograms. Now, this is different from first trimester abortion, medical abortion, because in second trimester abortion, you have to admit the patient. When you are doing first trimester abortion with medical abortion, you don't need to admit. Then in this case, it is like a mini labor. Now, there are various protocols which can be used. Between 200 to 800 micrograms, you have to give misoprost. There are various protocols, and the most commonly used protocol is you have to give 400 micrograms misoprost every 4 hourly. Right? So, that's the most commonly used protocol for giving misoprost. Clear? Okay. Now coming to the type of abortion. In the type of abortion, whenever you get a question on type of abortion, look at whether there is history of product of conception present or not. Right? Now, if there is history of passage of product of conception, then either you are dealing with incomplete abortion or you are dealing with a case of complete abortion. How are you going to differentiate between them? You are going to look at the internal os. If internal os is closed, it means you are dealing with complete abortion. If internal os is open, then it is a case of incomplete abortion. Right? Now, suppose if they say that there is no history of passage of product of conception, then in your mind you have to keep missed abortion as a DDD, as a differential diagnosis. You have to keep threatened abortion as a differential diagnosis, and you have to keep inevitable abortion as a differential diagnosis. Now, how am I going to differentiate between them? I am going to look in the question what they are telling me about the os. If they say os is open, then in that case, it means I am dealing with a case of inevitable abortion. Now, if they say, Arre Baba, you stop writing, ma'am, give the PDF. Actually, I'm telling you, my attention, is getting diverted. I am looking at your messages much more than I am concentrating here. So I will give you the PDF. Stop writing now. Give me the PDF. Right? Stop writing that in the comment box. I will share the PDF with you. But let me concentrate. Okay? Now, next is if the os is closed. Now, if the os is closed, either it can be threatened abortion or it can be missed abortion. To differentiate between them, you are going to look at the height of the uterus. If height of the uterus corresponds to the gestational age, then that means it is a case of threatened abortion. If height of the uterus is less than the period of gestation, then it is a case of missed abortion. Clear to all of you? Okay. Now, I also want you to tell me what is the ultrasound criteria for missed abortion. What is the ultrasound criteria for diagnosing missed abortion? So, there are two very important criteria which you have to remember. Number one, if mean sac diameter is more than equal to 25 millimeters and there is no fetal pole which is seen. That means crown rump length cannot be measured. Then that is a case of missed abortion. Number two, if crown rump length is more than equal to 7 millimeters and there is no cardiac activity, then that is the ultrasound criteria for missed abortion. Very, very important. Clear to all of you? Now, everything about cervical incompetence and about the cerclage surgeries I have covered in my PYQ session. That is also important. Then I will also cover a few other important points related to cerclage surgery in my upcoming session in the image-based session. Right? Now, coming to ectopic pregnancy. Ectopic pregnancy में most of the times the questions which they ask you is either on management of ectopic pregnancy or they ask you what is the next step, right? So in case of ectopic pregnancy, I want first of all that you read this question. What is this question? A 26-year-old female with 5 weeks amenorrhea with spotting PV, her UPT is positive, TVS shows empty uterus and there is no fluid in pouch of Douglas. What is the next line of management? And this is how most of the times questions are asked, right? So whenever you are getting a question where they say that there is amenorrhea plus bleeding PV plus UPT is positive and they ask you what is the next step is you have to do a TVS, which is already done in this case, right? Please remember that the most consistent or the most specific symptom of ectopic pregnancy is pain in abdomen, right? Now, in this case, because TVS is already done, so I am going to continue from here. कि TVS पे क्या findings मिलती हैं which are confirmatory that you are dealing with ectopic pregnancy, and TVS में what are the findings which tell you that no, it is not confirmatory for ectopic pregnancy. On TVS, if you are seeing a gestational sac with a yolk sac with or without cardiac activity in the tube. So if you are getting a gestational sac along with a yolk sac with or without cardiac activity in the tube, then it is a confirmed sign for ectopic pregnancy, and in that case the next step will be management of ectopic. So suppose इस question में इन्होंने TVS में finding दी होती, instead of saying empty uterus, if they would have said that a gestational sac is seen and a yolk sac is seen in fallopian tube, and they would have asked you the next step, then your next step would have been management of ectopic pregnancy, right? And then your answer would have been laparoscopy. Ideally the management is medical management, because यहाँ पे medical नहीं दिया है, so we are going to go for laparoscopy. But unfortunately ये question नहीं आया, right? So this is not the answer. Now, there are certain findings which you get in case of ectopic pregnancy on ultrasound which are not confirmatory for ectopic pregnancy. And these findings are if you are getting a gestational sac without a yolk sac in the tube. So अगर केवल gestational sac दिख रहा है fallopian tube में, then that is not confirmatory for ectopic pregnancy, right? So यहाँ पे अगर इन्होंने instead of saying that both yolk sac and gestational sac is given, अगर यहाँ पे केवल gestational sac देते in fallopian tube, then that is not confirmatory of ectopic pregnancy, right? Then similarly, if they say that on TVS a complex adnexal mass is seen, then that is also not confirmatory for ectopic pregnancy. If they say ring of fire sign is seen on Doppler, that is also not confirmatory for ectopic pregnancy. Many of you do this mistake. जैसे ही question में ring of fire sign आता है, you feel कि this is confirmatory for ectopic pregnancy. No, it's not confirmatory for ectopic pregnancy. Or if your question says empty uterus, then also it is not confirmatory for ectopic pregnancy. And any of these findings अगर दी हुई हैं question में कि on TVS any of these four दिया है, तो these are not confirmatory for ectopic pregnancy, and then your next step becomes beta HCG measurement, right? Now, if beta HCG comes out to be more than 2000 and still you are not seeing a gestational sac in the uterus, that means ectopic pregnancy is confirmed. So simply याद रखो, beta HCG more than 2000 है and it means कि it is ectopic pregnancy. Beta HCG less than 2000 है, then in that case you have to repeat HCG after 48 hours. Why are you repeating HCG after 48 hours? Because if you see that the HCG values in 48 hours nearly double, it means it's an intrauterine pregnancy. If you see that the values increase but they do not double, then it is ectopic pregnancy. And if you see that the values decrease, then that is abortion, right? So this flow chart is very, very important for you. Now, keeping this flow chart in mind, come to this question. Now the question is saying that there is a 26-year-old female who has amenorrhea, she has spotting PV, her urine pregnancy test is positive, TVS is showing empty uterus. Empty uterus is not confirmatory for ectopic pregnancy. That means your next step is going to be you have to measure beta hcg value. So you have to follow it up with beta hcg values, right? So option D is the correct answer over here. Now, discriminatory score, someone is saying 1500. No beta, it is not 1500. This was the recent values, and at this I have been telling you for past 1 year that the values have changed and it has become 2000 international unit, right? So the discriminatory score for HCG is 2000 international units. Now, एक और question on ectopic pregnancy which they ask quite oftenly, and that is, what is the management of ectopic pregnancy? So whenever you get a question on management of ectopic pregnancy, if your question is talking about ruptured ectopic, right? Ab ruptured ectopic, how are you going to know that your question is talking about ruptured ectopic? Because in the question they are going to say that patient has syncopal attacks. अगर क्वेश्चन में syncopal अटैक दिया है, या अगर क्वेश्चन में दिया है that the patient is in shock, या अगर क्वेश्चन में दिया है that she is having pelvic pressure, right? Then that means that they are talking about ruptured ectopic, right? Now, in case of ruptured ectopic, always the management is surgery, and the surgery which you do is salpingectomy, whether the family is complete or not. Hardly matters. Family complete or not. It doesn't matter, because if the tube is ruptured, you have to do salpingectomy. They try to confuse you by saying that the family is not complete. Even whether the family is complete, whether the family is not complete, you are going to go for salpingectomy. This salpingectomy can be done by laparotomy or by laparoscopy. If vitals of the patient are stable, you can do laparoscopic salpingectomy also. But if vitals are unstable, you have to do a open abdominal salpingectomy. That means laparotomy followed by salpingectomy, right? Now, this is not the case in unruptured ectopic. In unruptured ectopic, you can go for medical or surgical management, and the preferred management is medical management. Medical management can be done only if vitals of the patient are stable. Surgical management can be done in stable as well as unstable vitals, because surgical management can be done in case of ruptured ectopic as well. Now, if your question says कि vitals of the patient are stable and patient को unruptured ectopic है, so हमें लगता है कि unruptured ectopic है, vital stable है, so I'm going to go for medical management. But read your question very carefully. If your question says family of the patient is complete, अगर family complete है, then instead of choosing medical management, I'm going to choose surgical management, right? HCG levels for medical management, they should be less than 5,000 international units. If HCG is more than 5,000 international units, you have to go for surgical management. Size of the sac should be less than 4 centimeters. If it is more than equal to 4 centimeters, we will go for surgical management. Cardiac activity should be absent, then we go for medical management. If cardiac activity is present, we go for surgical management. But this is only a relative requirement. क्योंकि cardiac activity अगर present है, तो that doesn't mean that medical management is contraindicated. Only problem is that if cardiac activity is present and if you are doing medical management, there are increased chances of failure. So we prefer surgical management. Medical management is done with a single dose methotrexate, whereas surgical management is done laparoscopically. And in this case, the surgery depends upon whether the family is complete or not complete. If family is complete, then the surgery which I am going to do will be salpingectomy. But if the family is not complete, then I am going to do salpingostomy. When you are doing salpingostomy, you make a cut just above the place where ectopic is there. So in the tube, wherever the ectopic is located, just above that, you are going to make an incision. You are going to remove the ectopic pregnancy by hydrodissection, and then you are going to let the tube remain like this only. You do not suture it back, right? That is what is salpingostomy. Please remember, in case of ectopic pregnancy, ovaries are not removed unless and until it is an ovarian ectopic. So salpingo-oophorectomy is never done, right? As far as your expectant management is concerned, in case of expectant management will never be your answer of choice. You are never going to say that in a patient I am going to go for expectant management. This is because expectant management ke liye there are some stringent criteria which should be fulfilled. Number one, expectant management is done in an ectopic pregnancy which is automatically resolving, right? So they have to give you two values of HCG, and those values, आज की जो values हैं and day after tomorrow या tomorrow the values should be decreased. So they have to give you two values of HCGs which are automatically decreasing. Number two, in case of expectant management, patient should not come to you with any pain in abdomen. There shouldn't be any gestational sac which should be visible in the tube, and the values of HCG, they should be less than 200 international units. So expectant management बहुत rarely करते हैं. They are not going to ask you questions on expectant management. Clear? Now, one question which they may ask you is, what is the name of the criteria if there is an ovarian ectopic? Now, the name of the criteria for ovarian ectopic, it is Spiegelberg criteria. Spiegelberg criteria. Then for a cervical ectopic, it is Parmann's criteria or a Rubin criteria. Then for abdominal ectopic, it is Studiform criteria. Studiform criteria, right? So this is what you have to remember in ectopic pregnancy. Now, coming to gestational trophoblastic diseases. What are the points which you have to remember for gestational trophoblastic diseases? In gestational trophoblastic diseases, you have molar pregnancy and you have a gestational trophoblastic neoplasias, right? Now, in molar pregnancies, we have partial mole and complete mole. There are only two problems which come under molar pregnancy. In partial mole, the chromosome number is 69XXY. It is triploid and fetal tissue will be present. In case of complete mole is also called as vesicular mole, or it is also called as hydatiform mole. The chromosome number is 46XX. Patient of molar pregnancy will come to you with first trimester bleeding. Then question में दिया होगा, patient is having excessive vomiting, that is there is hyperemesis gravidarum. There is increased levels of thyroid hormones and there is early onset PIH. Question will say that the height of the uterus is more than the period of gestation, and question is going to show you an ultrasound जिसमें snowstorm appearance will be seen. All this points towards a complete mole, right? In case of partial mole, all these symptoms are present but to a lesser extent in comparison to a complete mole. Now, whenever you get a molar pregnancy, whenever you get a molar pregnancy, then the management which you have to say is that I am going to go for suction evacuation. But if your question says specifically that the age of the patient is more than 40 years and her family is complete, then in that case choose the answer as hysterectomy. You will say I'm going to do hysterectomy, right? If they ask you that what is the management for theca lutein cyst, there is no treatment needed for theca lutein cyst. जब आप suction evacuation करोगे for molar pregnancy, then automatically after some time this theca lutein cyst is going to resolve on its own. So no treatment needed for theca lutein cyst. So this they can ask you that what is the management of theca lutein cyst, and options में या तो दिया होगा नो ट्रीटमेंट या दिया होगा सक्शन इवैक्यूएशन. सक्शन इवैक्यूएशन का मतलब ये नहीं है कि थीका लुटियन सिस्ट का सक्शन इवैक्यूएशन. सक्शन इवैक्यूएशन मींस सक्शन इवैक्यूएशन ऑफ मोलर प्रेगनेंसी, राइट? Then investigation which you are going to do for follow-up. Investigation which you are going to do for follow-up is HCG. What is the investigation of choice in a molar pregnancy? It is TVS. What is the gold standard investigation in case of molar pregnancy? It is histopathological examination. So whether you are doing suction evacuation or whether you have removed the entire uterus, you have to send the tissue for histopathological examination and you have to follow it up with beta HCG levels. Follow up is done for 6 months, and for these 6 months pregnancy is contraindicated. The contraception of choice which you give in molar pregnancy is oral combined pills. Now, what are the signs and symptoms? Again, a very important thing, that what are the signs and symptoms that tell you that a patient of molar pregnancy has developed gestational trophoblastic neoplasia. So number one, if your patient is having persistent bleeding after suction evacuation, or if theca lutein cysts persist, then that indicates that it has changed into a GTN. If patient goes into shock, if there is subinvolution of the uterus, or if there are signs of metastasis. Most common site for metastasis in case of GTN, most common site is lungs, and the most common appearance which you get on chest x-ray when there is lung metastasis, it is cannonball appearance followed by snowstorm appearance. Followed by the snowstorm appearance. Right? The second most common site for metastasis is vagina. So if you are getting any of these signs and symptoms, then that indicates that patient has developed GTN, or if you are getting any of these lab investigations. So you have done HCG levels for 3 weeks, and in 3 consecutive weeks you are getting increasing HCG levels. How much increase? More than 10%. You have done HCG levels for 4 consecutive weeks, and in 4 weeks you are getting almost the same level. Almost the same level means within 10% of previous levels. If HCG can be detected even after 6 months of suction evacuation, or when you had sent the tissue for histopathological examination, the report is saying that GTN is present, then all this are signs and symptoms and lab investigations which tell you that your patient has developed GTN. Now, what is the most common GTN which develops after molar pregnancy? It is invasive mole. What are the other GTNs which can happen? It is choriocarcinoma, PSTT and ETT. Now, choriocarcinoma most commonly occurs after molar pregnancy. After full term delivery, which is the most common GTN? After full term delivery, the most common GTN is choriocarcinoma. So I have told you 3 questions. After molar evacuation, after molar pregnancy, which is the most common GTN? Invasive mole. After full term pregnancy, which is the most common GTN? Choriocarcinoma. Choriocarcinoma most commonly occurs after? It occurs after molar pregnancy, right? Now, whenever you are getting a GTN, specifically for invasive mole and for choriocarcinoma, management is chemotherapy. In case of stage 1 GTN, stage 1 GTN means that the tumor is limited to the uterus. The chemotherapy which you have to give is multi-dose methotrexate. In case of stage 4 GTN, stage 4 GTN का मतलब होता है that the tumor has spread to brain or to liver. In this case, you have to give imaco regime. So you don't have to use a single drug, you have to use many drugs, and this is what is imaco regime. Now, if it is a stage 2 or stage 3 GTN, stage 3 GTN का मतलब है lung metastasis, stage 2 का मतलब है vagina में metastasis. Now, if the metastasis is in lungs or vagina, that is stage 2 or stage 3. Now, in order to decide whether I have to give a single drug or whether I have to give imaco regime, we are going to do WHO scoring system. If WHO scores comes out to be less than equal to 6, that means it is a low risk disease. In this case, you are going to use only methotrexate, and that is multi-dose methotrexate. But if score comes out to be more than equal to 7, that's a high risk disease, and in high risk disease, you have to use imaco regime. Clear to all of you? In case of GTN, you have to do follow-up for 1 year, and for 1 year pregnancy is contraindicated. So it is only in stage 2 and stage 3 that you have to do a WHO scoring system. If score comes out to be less than equal to 6, it's a low risk disease, give methotrexate. Only methotrexate, but you have to give it as multi-dose. कैसे देते हैं multi-dose methotrexate? Day 1 पे देंगे, day 3 पे देंगे, day 5 पे देंगे, day 7 पे देंगे, and in between I'm going to give folic acid, right? And if it is a high risk disease, that means the score is coming as more than equal to 7, then you give imaco. Now, what does imaco stand for? E is for etoposide, M is for methotrexate, A is for actinomycin D, C is for cyclophosphamide, and O is for oncovin, right? Clear to all of you? Then, now comes important points on PIH. Now, when do you say that a female has hypertension? We say that a female has hypertension if her BP is more than equal to 140/90 on 2 occasions 4 hours apart. So, suppose a patient comes to you and her BP, एक बार हमने BP लिया and it is coming out to be 140/86. I am not going to call it as PIH. I am going to repeat her BP after 4 hours, and if still it is more than, so either systolic should be more than 140 or diastolic should be more than 90. This is one big area where you confuse. आपको लगता है कि दोनों 140/90 होगा तब जाके हम उसको high BP कहेंगे. No. Even if systolic is more than 140 or if diastolic is more than 90, you are going to call it as high BP, but then this reading should be taken twice, right? Now, the other thing which I want you to understand is, suppose a patient comes to you and her BP is more than equal to 160/110. So, either a systolic is more than 160 or a diastolic is more than 110. In that case, please do not wait for 4 hours. In that case, repeat her BP in 15 minutes, and still if her BP is increased, immediately give her antihypertensive. ये जो 4 hours हैं, ये केवल तब करते हैं if BP is more than equal to 140/90 but less than 160/110. अब PIH में जो most important thing which they ask you is classification. They are going to give you a scenario and you will have to classify whether it is which type of hypertension is happening in pregnancy. You will have to recognize that. So, suppose your question says that BP is more than equal to 140/90 at less than 20 weeks of pregnancy. सो कभी भी बीपी मोर देन 140/90 है at less than 20 weeks of pregnancy, that means it is a case of chronic hypertension in pregnancy. Right? This is a case of chronic hypertension. Now what has happened? अच्छा, पीडीएफ प्रोवाइड कर देंगे, बट प्लीज बार बार मेरे को डिस्टर्ब मत करो. ओके. So, if the patient's BP is more than equal to 140/90 at less than 20 weeks, it is chronic hypertension in pregnancy. Now, suppose आपका question ये कहता है कि BP is more than equal to 140/90 at less than 20 weeks, but suddenly at 20 weeks, her BP became uncontrollable. She started having proteinuria or she started having signs of end organ damage, any of these three things. Then you are going to change your diagnosis and you are going to call it as chronic hypertension with superimposed preeclampsia. Right? Then, now suppose your questions gives you a third situation. Question says that the patient's BP is high. For the first time, this high BP happened after 20 weeks. So this high BP happened after 20 weeks. There is no proteinuria and there are no signs of end organ damage. Now your diagnosis is going to be gestational hypertension. So if BP is more than equal to 140/90, right, but there is no proteinuria, there are no signs of end organ damage, then that is gestational hypertension. Right? Now, suppose they say that BP is more than equal to 140/90 and this increase in BP is happening after 20 weeks. Proteinuria present hai ya signs of end organ damage present hai, any of them is present, then your diagnosis is going to change and now your diagnosis is going to become preeclampsia. Now you are going to say that the diagnosis is preeclampsia. Right? Now, so if signs of proteinuria या signs of end organ damage present हैं and BP is increasing after 20 weeks, then it is preeclampsia. If BP is increasing after 20 weeks and there are no signs of proteinuria nor there are signs of end organ damage, then that is gestational hypertension. A preeclampsia में, whenever you are making a diagnosis of preeclampsia, the next thing which you should check is what BP have they given and whether they have given you signs of end organ damage or not. Agar BP, if BP is more than equal to 140/90, if BP, I don't know what has happened to my pencil today. If BP is more than equal to 140/90, but less than 160/110, or there are no signs of end organ damage, then this is mild preeclampsia. If BP is more than equal to 160/110 or if signs of end organ damage are present, then this is severe preeclampsia. Severe preeclampsia के लिए there are two criteria. One is BP criteria and another is signs of end organ damage criteria. So signs of end organ damage present हैं or if BP is more than equal to 160/110, then you call it as severe preeclampsia. Right? Severe preeclampsia के patient में अगर convulsions आ जाते हैं, then that is what is eclampsia. Tick? Agreed? Okay. Now, so if you've understood the classification of various hypertensive disorders which can happen in pregnancy, now let us deal with management. Now, whenever they are asking you management of mild PIH का मतलब BP is more than 140/90 but less than 160/110. Management में number one is antihypertensives ka there is no role. There is no role of antihypertensives. Nice guideline says, nice guideline कहते हैं कि if BP is more than 150 by 100, then you may give antihypertensives, right? But otherwise, as such, we don't give antihypertensives for mild preeclampsia. Mild preeclampsia, see, preeclampsia क्यों होता है? It happens because of a problem which is there in the placenta. And what problem is there? Just now we will revise that also quickly. So always the best management for hypertensive disorders is, or the definitive management for hypertensive disorders is termination of pregnancy. And termination of pregnancy in case of mild preeclampsia, you do it at more than equal to 37 weeks, right? Then severe PIH ka management. Severe PIH ke management mein, number one, you have to give antihypertensives. Antihypertensives 100% देना है. Antihypertensive which you can give is labetalol, you can give hydralazine, or you can give nifedipine. ठीक? Now, because severe PIH के patient में, patient anytime can throw convulsions and she can have eclampsia, so you have to give magnesium sulfate to prevent convulsions. You have to give magnesium sulfate. And number 3, termination of pregnancy, that is the definitive management. And when are you going to do termination of pregnancy? At more than equal to 34 weeks. Another very important question is, because severe PIH ke patient mein there can be eclampsia. So what are the signs of impending eclampsia in a patient of severe PIH? So if your patient of PIH is having headache, if she is having epigastric pain, or if she is having visual symptoms, then it means that she can throw convulsions at any time. So you are going to give her magnesium sulfate, you are going to give antihypertensive, and you are going to do termination of pregnancy at more than equal to 34 weeks. Eclampsia ka patient. Eclampsia ka patient is throwing convulsions and coming to you. So the first step in management is either of the two. Either airway management दिया होगा options में, या it will be you have to prevent the patient from falling, and that is why you have to prevent the patient from falling down. So you have to raise the bed rails, right? Then number 2, because she is throwing convulsions, you are going to give magnesium sulfate. Because her BP will be high, you are going to give antihypertensives. And again, which antihypertensives? Labetalol, hydralazine, or nifedipine, right? And you are going to go for immediate termination of pregnancy. Have you understood? That is the management for eclampsia. As far as how to give magnesium sulfate is concerned, what is the Pritchard regime and what are the toxicities which are seen with magnesium sulfate, everything I have covered with you in the PYQ session. So everything related to magnesium sulfate is covered there. Right? Now, what are the conditions where you are going to do immediate termination of pregnancy in a patient of preeclampsia or in a patient of PIH? So, if your patient has impending eclampsia, or if your patient is a patient of HELP syndrome, again, everything related to HELP syndrome I have taught in the Chalo PYQ session. If your patient has uncontrollable BP, तो कोई भी acute event हो रहा है, तो you are not going to wait for termination of pregnancy, you are going to do immediate termination of pregnancy. For example, impending eclampsia, HELP syndrome, uncontrollable BP, placental abruption, DIC, if your patient has MI, stroke or pulmonary edema, or if there is fetal distress. In all these cases, you are going to give the first dose of corticosteroid and you are going to immediately deliver. You are not even going to wait for 48 hours to give the next dose. No, you are not going to do that. Clear to all of you? Yes? Then, now, coming to a very important point on PIH where they ask you questions. They will ask you question on the pathophysiology of PIH. So if you remember in the Cello PYQ session, I told you that in case of PIH, there is incomplete trophoblastic invasion by the extravillous cytotrophoblast, right? Now, extravillous cytotrophoblast की जगह endovascular cytotrophoblast भी दिया हो सकता है. Now, you people are asking me that in case of PIH, how are we going to terminate pregnancy? We are going to terminate pregnancy by induction of labor. Always in PIH we go for vaginal delivery. Cesarean section is only reserved for obstetrical indications, right? And suppose question पूछा जाए that there is a patient of PIH जिसमें due to some reason you are doing cesarean section, then what is the anesthesia of choice? The anesthesia of choice will be न्यूरेक्सियल एनेस्थीसिया. दैट्स द बेस्ट आंसर. अगर न्यूरेक्सियल एनेस्थीसिया ऑप्शन में नहीं दिया होगा, देन द सेकंड बेस्ट आंसर इज गोइंग टू बी एपिड्यूरल एनेस्थीसिया, राइट? सो ऑलवेज इन केस ऑफ PIH, टर्मिनेशन ऑफ प्रेगनेंसी का मतलब है इंडक्शन ऑफ लेबर, right? Unless and until there is some obstetrical indication for cesarean section. Clear? Okay. Now coming to a very important thing. So as I was telling you, pathophysiology may remember it is due to incomplete trophoblastic invasion. ये आप सबको याद रहता है. What you forget is that it is because of this incomplete trophoblastic invasion is of extravillous cytotrophoblast or endovascular trophoblast, which are the cells which play a very important role in vascular remodeling. Which cells play a very important role? So it is mother's natural killer cells which play a very important role in vascular remodeling, right? Now remember that there are certain mediators which are increased in a case of PIH and there are certain mediators which are decreased in a case of PIH. Vasoconstrictors increase करते हैं and vasodilators decrease करते हैं. So SFLT1 increases in PIH. There is increased serum endoglin levels and endothelial levels. Endothelin levels increase in PIH. Vascular endothelial growth factor decreases, placental growth factor decreases, nitric oxide decreases, and prostacyclin levels decrease in PIH. Very, very important. It has been asked in your INI set exam and this may be asked in your NEET exam, right? So SFLT1 and endoglin levels and endothelin levels increase. Then nitric oxide, prostacyclins, vascular endothelial growth factor and placental growth factor levels decrease. To predict PIH, I told you, you have to do uterine artery Doppler, which is normally done between 22 to 24 weeks. These days, we are doing it between 11 to 13 weeks to go for early onset preeclampsia, to diagnose early onset preeclampsia. To prevent PIH, the drug of choice is aspirin. This is something new which came in your Williams, and that is in what are the risk factors where you have to give aspirin. वो कौन सी conditions होती हैं where you have to give aspirin to prevent PIH. So for that, the mnemonic which you can remember is all hypertensive mothers can die. Right? So A stands for APLA. In APLA syndrome, you have to give aspirin. Then hypertensive stands for previous history of PIH. You have to give aspirin. If it is multifetal pregnancy, you have to give aspirin. If mother has kidney disease, you have to give aspirin. If diabetes mother has, you have to give aspirin. So all hypertensive mothers can die. In these conditions, you have to give aspirin to prevent PIH. There is no role of bed rest. There is no role of antioxidants to prevent PIH. There is only role of aspirin to prevent PIH. This aspirin should be started between 11 to 14 weeks and it should be continued up till 36 weeks. Right? And you have to give low dose aspirin, 75 to 180 mg of aspirin. Right? So this is what you have to remember in case of PIH. Now, Coming to what are the important points which you have to remember in case of diabetes. So in diabetes, what you have to remember is that for the diagnosis of diabetes in India, we follow the DIPSI criteria. According to the DIPSI criteria, the DIP test you are going to do at the first antenatal visit, and then you are going to repeat it between 24 to 28 weeks. No fasting is needed, and you have to give glucose, 75 grams of glucose, and then you are going to check blood sugar levels after 2 hours. If after 2 hours blood sugar levels are less than 140, then there is no diabetes. If levels are more than equal to 140, then GDM, gestational diabetes. If levels are more than equal to 200, then it is a case of pre-gestational diabetes. Right? The IAD-PSG criteria to diagnose gestational diabetes. So for gestational diabetes, the IAD-PSG criteria or the American Diabetes Association criteria is, see, most commonly you have to remember DIPSI. Lekin IAD-PSG has been asked in INI set, that is why I am telling you here. So according to IAD-PSG criteria, the testing can be done between 24 to 28 weeks. Fasting is necessary for that test. And again, you are going to give 75 grams of glucose, and you are going to check her fasting blood sugar levels, 1-hour-PP levels and 2-hour-PP levels. Cutoff for fasting blood sugar is 92. For 1-hour-PP, it is 180. And for 2-hour-PP, it is 153. 92 पे question आया था. Now, out of, so remember it is 92. Many of you at that time marked it as 95. It is 92. Out of these three values, if one or more than one value is abnormal, then you can diagnose it as a case of gestational diabetes. Now, for pre-gestational diabetes or overt diabetes, the criteria is fasting if it is more than equal to 126. If 2-hour-PP is more than equal to 200, or if HbA1c is more than equal to 6.5, then you make a diagnosis of pre-gestational diabetes. Now, once the diagnosis is made, and if you have a patient of gestational diabetes, first thing what you are going to do is you are going to put her on diet modification. And this diet modification has to be continued for 2 weeks. After 2 weeks, you are going to check her 2-hour-PP value. If her 2-hour-PP value is less than 140, that means उसकी blood sugar diet modification से control हो गई है. So you will continue diet modification, and you are going to monitor her 2-hour-PP levels regularly. Why am I monitoring her 2-hour-PP levels regularly? Because insulin requirements increase in pregnancy and insulin resistance also increases in pregnancy. So जैसे जैसे pregnancy advance होगी, insulin resistance बढ़ेगा, तो maybe diet is sufficient just now to control her blood sugar, but after some time it might not be sufficient. So that is why if your patient is on diet modification, regularly you have to check her 2-hour-PP levels. Our national guidelines say that up till 28 weeks of pregnancy, you have to check her blood sugar levels once in 2 weeks, and after 28 weeks, you have to check her blood sugar levels once in a week, right? Now, if her 2-hour-PP levels at any point of time, they come out to be more than equal to 140, then that means you have to start insulin, because the drug of choice for treating diabetes is insulin. And now once you have put her on insulin, then you are going to measure her 2-hour-PP values initially after every 2 days. Initially after every 2 days, and then once her blood sugar levels are stabilized, so you are going to measure her values after every 2 days and simultaneously increase the dose of insulin. And एक बार उसका blood sugar levels they get stabilized, then you check it every weekly. Other than that, in all patients of gestational diabetes, you are going to do a level 2 scan at 18 to 20 weeks. Now, because gestational diabetes does not lead to congenital malformation, that doesn't mean कि हम उनमें level 2 scan नहीं करेंगे. Level 2 scan has to be done in all pregnant females. So, in gestational diabetes also, I have to do a level 2 scan at 18 to 20 weeks. Then from 32 weeks onwards, because diabetes is a high risk pregnancy, I will do antepartum fetal surveillance, and I am going to do her ultrasound for fetal growth, not only for fetal growth, also to check polyhydramnios, because in diabetes polyhydramnios is common. Then When do I terminate pregnancy? If it is well controlled diabetes, then the termination of pregnancy has to be done around 39 weeks. But if diabetes is not well controlled, then it has to be done between 37 to 38 weeks. This is the management of gestational diabetes. In case of overt diabetes, there is no role of only diet modification. Never do you say कि हम केवल diet modification करेंगे. The moment you make a diagnosis of overt diabetes, you have to put your patient on insulin plus diet modification, plus you are going to put her on aspirin. As I told you just now, all hypertensive mothers can die. D was for diabetes. So in all diabetic patients, I have to give aspirin to prevent PIH. So जितनी भी overt diabetes की patients होती हैं, I have to give them aspirin to prevent diabetes. Investigations जितने हम gestational diabetes में करते हैं, all those investigations I have to do in overt diabetes also. Plus in overt diabetes, I have to do fetal echo because congenital malformations are seen in overt diabetes, and the most common congenital malformations are related to cardiovascular system. So gestational diabetes mein fetal echo is not needed, but in overt diabetes, fetal echo is needed. Complications of diabetes, maternal complications of diabetes may, it can lead to infection, it can lead to preterm labor, and it can lead to polyhydramnios. Because of polyhydramnios, they can be placental abruption, they can be PPH, they can be cord prolapse. Then there are increased chances of PIH and increased diabetes in future. Fetal complications of diabetes, very important. The most common fetal complication of diabetes is macrosomia. Macrosomia can lead to shoulder dystocia. In fetus, again, there is hyperglycemia. Then there can be abortion, IUD, stillbirth, and rarely in a case of diabetes आपको oligohydramnios या IUGR मिल सकता है. When do you get oligo or IUGR in a case of diabetes? If it is a case of diabetes with vasculopathy. If your patient has diabetes with vasculopathy or she has diabetes and PIH, then rarely you may get oligohydramnios or IUGR in a case of diabetes. Congenital malformations, they are seen only in pregestational diabetes. So if they ask you that what is the dose of folic acid which you give to a patient with diabetes, it is 400 micrograms. Do not say 4 milligrams, right? The most common congenital malformation which you get is VSD, followed by neural tube defect. The most specific congenital malformation which you get is sacral agenesis, and the most specific cardiac malformation which you get is TGA. In neonate, you are going to get hypoglycemia, hypocalcemia, hypomagnesemia, hypokalemia, hyperviscosity syndrome, hyperbilirubinemia, polycythemia, respiratory distress syndrome, and necrotizing enterocolitis. Right? Now, in entire OBS, they do not ask you many questions on risk factors, but agar risk factors पूछेंगे, so they are going to ask you risk factors from 5 places. One is risk factors of PIH. Another is risk factors for placenta previa. Third is risk factors for abruptio. Fourth is risk factors for PPH, and 5 is risk factors for endometrial cancer. So I have written all those risk factors over here. Risk factors for PIH, risk factors for PPH, placenta previa and abruptio, and I have also written risk factors for endometrial cancer. Since you people are saying that to provide these slides to you, so this is something which you are going to study on your own. All the risk factors are written over here. This is a very, very important slide, right? Then there are certain named classifications which you should be knowing in case of OBGY. So number one is page classification. Page classification is used for abruptio. In abruptio, you have grade 0, grade 1, grade 2 and grade 3. ग्रेड 0 का मतलब है रिट्रोप्लेसेंटल क्लॉट, दैट मीन्स पेशेंट को कोई सिम्टम्स नहीं आए थे एपीएच के. आफ्टर डिलीवरी आई सॉ रिट्रोप्लेसेंटल क्लॉट एंड आई मेड द डायग्नोसिस ऑफ एब्रप्शियो. ग्रेड 1 मीन्स पेशेंट को ब्लीडिंग हो रही है, पेन इन एब्डोमेन हो रहा है, बट फीटल हार्ट साउंड्स इज नॉर्मल. ग्रेड 2 मीन्स पेन एंड ब्लीडिंग तो होगा ही बिकॉज दैट इज अ सिम्टम ऑफ एब्रप्शियो, बट नाउ देयर इज फीटल डिस्ट्रेस. ग्रेड 3 मीन्स there is fetal death plus mother is in shock, or if there is DIC. So if there is fetal death, or if their mother is in shock, or if there is DIC, that is grade 3. Please remember, in abruptio, per vaginal examination is not contraindicated, only if you have ruled out placenta previa. Once you've ruled out placenta previa, you can do a per vaginal examination in a patient of abruptio. The first investigation which you do in case of APH is transabdominal scan, and the investigation of choice for placenta previa is TVS. The new classification for placenta previa, so according to the new classification, we have placenta previa and low-lying placenta. In my PYQ session, I told you that placenta previa is जो previous classification में type 2, type 3 and type 4 था. That is now placenta previa. And previous classification में जो type 1 था, that is low-lying placenta. Always, whether it is a low-lying placenta or whether it is placenta previa, management is cesarean section, right? Then comes Priscilla White classification. Priscilla White classification is a classification of diabetes जिसमें we have type A diabetes and non-type A diabetes. Type A diabetes का मतलब है gestational diabetes, non-A का मतलब है pre-gestational diabetes. This is what I want you to remember. अब type A में we have type A1 and A2. A1 का मतलब है gestational diabetes which is controlled on diet. A2 का मतलब है gestational diabetes which is controlled on drugs. That drug can be insulin, that drug can be metformin. Non-type A का मतलब है pre-gestational diabetes. Remember, in diabetes, the drug of choice is insulin. The second point which you have to remember, gestational diabetes may be drug of choice insulin है, but if patient refuses to take insulin, you may give metformin. But in case of pre-gestational diabetes, whether patient wants or doesn't want, always you have to give insulin. You can never use metformin to treat pre-gestational diabetes. Then there is a WHO classification for heart disease. WHO classification for heart disease में there are 4 classes, and all heart diseases are classified based on how much maternal mortality and morbidity they lead to. I am on slide 16 and there are slides 28. Right? So there are 12 more slides remaining. I don't know when we are going to complete this session today. If you have got tired, I can end it over here, but I'm not going to take this session again now. Whatever is done today is done. After this is an image-based session. Now, don't want you to remember the entire WHO classification. I just want you to remember WHO class 4. WHO class 4 of heart diseases में वो heart diseases आती हैं where there is absolute contraindication to pregnancy, right? So if they ask you in which heart diseases pregnancy is absolutely contraindicated, that comes in WHO class 4. Now, absolute contraindicated to tab hai na, if patient is coming to me in the preconception period and she's asking me, should I conceive or not? But if patient conceives and comes, then I'm going to tell her, please go and get an MTP done. So whether they ask you what are the heart diseases where pregnancy is contraindicated, or whether they ask you what are the heart diseases where MTP is indicated, these are the heart diseases. Yes, these slides includes gynae also. So both obs and gynae I'm completing today. So there are 10 heart diseases where pregnancy is contraindicated which come under WHO class 4. Number 1, if left ventricular ejection fraction becomes less than 30%. Please remember, in pregnancy, normally left ventricular ejection fraction remains normal. कभी भी left ventricular ejection fraction decrease नहीं होता, and normal ejection fraction is more than equal to 55%. So if in pregnancy, any time due to any heart disease, if left ventricular ejection fraction is becoming less than 30%, then that's a contraindication to pregnancy. Number two, wherever there is severe mitral stenosis means area less than 1.5 centimeter square. Severe aortic stenosis, again severe aortic stenosis means area less than 1 centimeter square. Whether it is severe aortic stenosis or mitral stenosis, दोनों cases में left ventricle ejection fraction will decrease, so automatically that becomes a contraindication. Then any heart disease which belongs to NYHA class 3 or class 4, that is a contraindication. Pulmonary hypertension, if there is any heart disease जिसमें pulmonary hypertension हो रही है, this pulmonary hypertension could be primary or it could be secondary. An example of secondary pulmonary hypertension is Eisenmenger syndrome, right? Then Marfan syndrome and bicuspid aortic valve. Please remember, normally Marfan syndrome is not a contraindication. But if there is Marfan syndrome with aortic root dilatation, or if there is a bicuspid aortic valve with root dilatation, in other words, severe coarctation of aorta, then that is a contraindication to pregnancy. Now, if you are not a Marrow subscriber, then and you have been reading, I don't know from where, these are the two contraindications which you should add in your notes. ये दो contraindication है जो अभी recently add हुए हैं in Williams. To all the Marrow subscribers, you have done this with me already. I have updated edition 6 as per the new Williams. So these are the two new contraindications to pregnancy. One is Fontan surgery. Remember, Fontan surgery वो surgery होती है which is done in hypoplastic left heart syndrome. तो अगर आपने Fontan surgery करी and there is some residual defect, or if your patient has history of peripartum cardiomyopathy with residual defect, then these are contraindications for pregnancy. So these are 10 heart diseases where pregnancy is contraindicated. So I was talking to you about named classifications. Named classification में एक और name which you have to remember is Robson's classification. Robson's classification, it came in your INI set. Robson's classification को 10 point classification भी कहते हैं, and Robson's classification is for comparing the rate and the indications for cesarean section. So ये institutions में basically use होता है to see what are the major indications for cesarean section and what are the rates for cesarean section for those major indication. Just the name Robson's classification, which is also called as 10-point classification. So these are the various named classifications which you have to remember in OBGY. Then you have to remember Bishop scoring. Now I am sure if you are a Marrow subscriber, you know this, that Bishop score के लिए I tell you a mnemonic, and that is Delhi Police Employed Special Commandos. Where D stands for dilatation of the cervix, P stands for position of cervix, E stands for effacement of cervix, S stands for station of fetal head, and C stands for consistency of cervix. Now, Bishop score is done before you go for induction of labor. So, before you go for induction of labor, you are going to do a Bishop score and you are going to check the score, right? Now, induction of labor के लिए please remember Bishop score का जो maximum score होता है that is 13. And if score is less than equal to 5, then it is a poor score. If score is more than equal to 6, then induction of labor can be done, and your Williams says that if score is more than 9, If the score is more than 9, then there are high chances of success of induction of labor. Right? So this is Bishop score. I want ki now what you are going to do. I don't know whether you people have prepared a 20th notebook or not. If you have prepared a 20th notebook, the bifurcation of the score should go in. ये कभी भी याद नहीं रहता है, right? कि how to calculate Bishop score, and neet में sometimes they ask you to calculate the Bishop score. So I want all of you to please write this down in a piece of paper and stick it either on your wall or in your 20th notebook, how to calculate Bishop score. It is very, very important. The other important thing is modified Bishop score may, instead of effacement, the parameter which you use is length of cervix, and length of cervix is always measured by TVS. I know you people are always my students for OBGY, and this is the reason why I am bringing out these sessions for you. Already for Marrow students, the revision videos have been uploaded long time back because I did not want you people to miss out. This is the reason why I am bringing out these videos for you people, especially because, as I say, all of you are my bachas. Right? No matter to which app you subscribe, no matter to which coaching you go. But for OBGY, I know you follow me blindly, and that is why I have to give you the most and the maximum. Okay. So yes, Suraj, in modified Bishop score, it is the effacement which is replaced by length of cervix. Right? Clear to all of you? Bishop score. Now, there is one more score which you are going to remember, and that score is biophysical score. So there are two scores which you have to remember. One is biophysical score and the other one is Bishop score. Biophysical score is, it is the diagnostic test for knowing whether the fetus is well or not. So what are the indications for biophysical score? Indication for biophysical score is whenever you get a non-stress test, non-reactive. If NST is non-reactive, whenever you get a non-reactive NST, it should be followed by a biophysical score. Biophysical score कैसे calculate करते हैं? Biophysical score is calculated by ultrasound. On ultrasound for 30 minutes, you have to see the following parameters. What are the parameters? TB meningitis always notorious. TB meningitis always notorious. T stands for, one second, AVI, modified Bishop score ka bifurcation you don't need to know. You need to know the bifurcation only for Bishop score. See, practically we use Bishop score because Bishop score mein we are using effacement. Effacement is checked clinically, and length of the cervix is checked with the help of ultrasound. That is why modified Bishop score is never commonly used, and kabhi bhi modified Bishop score mein you will never get to calculate a modified Bishop score. Right? Now coming to biophysical score. In biophysical score, it is TB meningitis always notorious, where T stands for fetal tone. So in 30 minutes, if you are getting more than one episode of flexion and extension, so agar limbs में more than one episode मिल रहा है, one or more than one episode of flexion or extension, that means you are going to give a score of +2. Right? If you are not getting any extension or any flexion, then you are going to give a score of 0. Next thing which you have to see is breathing movements. In 30 minutes, you should get one or more than one episode of breathing. अब actually breathing तो fetus में begin होती है after delivery. Right? ये जो हम breathing देख रहे हैं, this is chest wall movement. So you should get one or more than one episode of chest wall movement, and that should last for 30 seconds. अगर ऐसा मिल रहा है तो the score will be given as +2. Then gross body movements. In a period of 30 minutes, you should get 3 or more than 3 movements. If you are getting 3 or more than 3 movements, you will give a score of +2. Then you are going to look at the single largest vertical pocket. So there should be at least one single largest vertical pocket measuring 2 by 2 centimeters. If you are getting this, then the score will be again +2. I don't know what has happened to my pencil. Then it is NST. You are going to do NST, and if you are getting 2 or more than 2 accelerations in a period of 20 to 40 minutes, then you are going to give a score of +2. So in case of biophysical score, to each of these parameters, you either give a score of +2 or you give a score of 0. कुछ भी in between नहीं होता. Either it has to be +2 or 0. So maximum score which you can get is 10 by 10. So if you are getting a score of 10 by 10, or if you are getting a score of 8 by 10 with amniotic fluid volume normal. So ये वाला जो पैरामीटर था amniotic fluid volume वो normal है, but the score is 8 by 10. In either cases we say that the fetus is normal and we have to repeat this test weekly. Right? Now if you are getting a score of 6 by 10, score 6 by 10 hai, but again amniotic fluid volume is normal. That is an equivocal result. In this case, if the gestational age is more than equal to 37 weeks, please deliver the baby. But if gestational age is less than 37 weeks, you have to repeat the test in 24 hours. Now comes if the score is 8 by 10 or 6 by 10, but amniotic fluid volume is decreased. In that case, you have to deliver at 36 weeks. If score is 4 by 10, deliver at 32 weeks. So remember, 6 by 10 में delivery हो रही है 6 by 10 with normal amniotic fluid, delivery हो रही है 37 weeks पे. Amniotic fluid decreased है and 8 by 10 है या 6 by 10 है तो डिलीवरी हो रही है 36 वीक्स पे. 4 by 10 है तो डिलीवरी हो रही है at 32 weeks. And if it is 2 by 10 or 0 by 10, immediate delivery. All of you are going to note down this. This is what is new in Williams, or the how to treat what is the next step if biophysical score is 10 by 10 or 8 by 10 or 6 by 10 or 4 by 10. So this is very, very important, right? Okay. Now, again, something new which I want to tell you here. CDC ने दिए हैं contraindications to breastfeeding. This is something new which has come up. If you are a Marrow subscriber, I want you to write this again. And if you are not a Marrow subscriber, you have to write it. If you are a Marrow subscriber, please note this down. This is something new which has come. CDC's contraindications for breastfeeding. So CDC कहता है there is one absolute contraindication for breastfeeding, and that is if there is galactosemia. If baby has galactosemia, then that is an absolute contraindication for breastfeeding. Other contraindications for breastfeeding are if mother is on any anti-cancerous drug, or if she is on any chemotherapeutic agent, or if she is a IV drug abuser, if mother has infections like brucellosis, HSV, Ebola virus, HTLV1 or HTLV2, if mother has chicken pox and this chicken pox has happened within 5 days prior to delivery or 2 days after delivery, if there is active TB infection. In case of active TB infection, if a female has taken ATT for 2 weeks, then she can breastfeed the baby. In India, HIV is not a contraindication for breastfeeding. So brucellosis, HSV, Ebola virus, HTLV1, HTLV2, varicella zoster, which has happened within 5 days prior to delivery or 2 days after delivery, active TB infection. All these are contraindications to breastfeeding. I don't know. Is the live session still going on? In my this, it is showing. Are you able to see me and can you hear me? Is there some problem with my internet? Because I can't see you all. My this is showing that no, I am not visible. Acha, going on. Chalo. Then I won't waste time if you people are going on. Chalo. Right? Now, so I was telling you about we have done bishop score, we have done biophysical score. Now, important point on twins. Very, very important. Now, twins may, all of you know that there are four varieties of twins: dichorionic, diamniotic, monochorionic, diamniotic, monochorionic, monoamniotic, and conjoined twins. Right? So, dichorionic, diamniotic, all dizygotic twins are dichorionic, diamniotic. Monozygotic twins may, if division happens at less than 4 days, that means in a morular stage, then you get dichorionic diamniotic twins. Dichorionic diamniotic twins always have best prognosis. On ultrasound, in dichorionic diamniotic twins, you will see two placentas. You are going to get thick membranes between the twins, and twin peak sign or lambda sign will be positive. Please remember that in the image based session which I am going to conduct, I will show you placentas of various twins and I will also show you this twin peak sign. Just now I want you to remember that dichorionic diamniotic twins may, there are thick membranes between the twins. So if you draw dichorionic, quickly draw dichorionic diamniotic twins. So this over here is chorion, this is amnion, this is twin 1, this is twin 2. This is chorion of first twin, this is amnion of first twin, this is chorion of second twin, this is amnion of second twin. So what you are seeing? You are seeing thick membranes between the twins. There are 4 layers of membranes, or the thickness is more than equal to 2 millimeters. Right? Now comes monochorionic diamniotic twins. Monochorionic diamniotic twins हमें तब मिलेंगे when a monozygotic twin में division happens between 4 to 8 days. That means in the blastocyst stage. Now, in case of monochorionic diamniotic twins, on ultrasound, membranes will be thin. They will be less than 2 millimeters and twin peak sign will be absent. You are going to get a T sign present. Right? Now, let us draw monochorionic diamniotic. This is monochorionic diamniotic. Amnion, amnion, chorion. Right? So both the twins are surrounded by single chorion and separate amnions. So as you can see over here, the membranes will be having only 2 layers and they will be less than 2 millimeters thick. Now, monochorionic twins always have bad prognosis क्योंकि monochorionic twins में there are certain specific complications which you get. Monochorionic diamniotic twins में the complication which you get is number 1, twin to twin transfusion syndrome. In twin to twin transfusion syndrome, there is deep connection between artery and vein of the twins. एक twin की deep artery is connected to deep vein of the other twin. So, donor twin में you are going to get anemia. You are going to get oligohydramnios. Anemia होगा, oligohydramnios होगा. And because there is anemia, there will be decreased renal blood flow. So there is going to be renal failure. There are chances of heart failure and the growth will be less. The most important thing which you have to remember that in case of twin to twin transfusion syndrome, you get oligohydramnios in donor twin. Right? Whereas in recipient twin इसके उल्टा होगा. There will be polycythemia, polyhydramnios. Polycythemia की वजह से there will be increased chances of thrombosis. Then there are increased chances of congestive heart failure and the growth will be increased. Now, whenever you have monochorionic diamniotic twins, delivery should be done between 34 to 37 weeks. Why this bigger range? The range is so big because if the twins do not have twin to twin transfusion syndrome, do the delivery at 37 weeks. अगर twin to twin transfusion syndrome present है तो do it near 34 weeks. Dichorionic diamniotic twins में delivery is done at 38 weeks. Very, very important, right? Now suppose there is a vascular connection in monochorionic twins, but then that vascular connection is very small and it is leading only to hemoglobin difference. It is not leading to any difference in amniotic fluid. Then that is called as TAPS. What is TAPS? Twin anemia polycythemia sequence. Twin anemia polycythemia sequence. Difference between twin to twin transfusion syndrome and twin anemia polycythemia sequences. Twin to twin transfusion syndrome में हमें amniotic fluid में difference मिलता है. In donor twin there will be oligohydramnios. In recipient twin there will be polyhydramnios. Twin anemia polycythemia sequence में there is no difference in amniotic fluid. Only the difference is in hemoglobin levels. Right? Then a third problem can be seen in monochorionic diamniotic twins, and that is TRAP. That is twin reversed arterial perfusion. TRAP stands for twin reversed arterial perfusion. Twin reversed arterial perfusion. So today I don't know what has happened to my pencil that I can't write properly. Twin reversed arterial perfusion. अब इस condition में क्या होता है? In this condition, one twin is absolutely normal, other twin doesn't have an heart. Other twin is a cardiac twin. तो जो a cardiac twin है, it will get deoxygenated blood from the normal twin through umbilical artery. Right? So the A cardiac twin को blood आएगा which will be deoxygenated and it will be brought by umbilical artery. Normally in fetuses, blood is brought to the fetus by umbilical vein. In this condition, the twin is getting blood via umbilical artery and that blood is deoxygenated, and that is why it is called as twin reversed arterial perfusion. Right? Because this twin doesn't have any heart, so ये जो deoxygenated blood आया है, it may lead to development only of lower limbs, and that is what is called as acardious acephalus. Acardious acephalus में you are going to get a twin जिसके केवल lower limbs developed हैं. Or it can be acardious amorphous. That means no structure is developed. So you will see a twin. I will show you all these images on 21st. So you will get a twin and इस twin के साथ एक piece of mass attached है बस. एक normal twin है and इस normal twin के साथ only a piece of mass is attached. You cannot identify any structure. That is what is acardious amorphous. If you can identify only the lower limbs, that is acardious acephalus. Right? Now, so these are complications of monochorionic diamniotic twins. Now, if division is happening at more than equal to 8 days, then it results in monochorionic monoamniotic twins. In monochorionic monoamniotic twins, this is chorion, single amnion, and this is how the fetus are lying. So दोनों fetus की umbilical cord is in the same amniotic fluid, and that is why the complication which can happen is cord entanglement. Right? So there are no membranes between the twins. This can lead to cord entanglement, and in this condition cesarean section is to be done. Cesarean section is done between 32 to 34 weeks. Right? Then comes, if division is happening at more than 12 days, it results in conjoint twins. Conjoint twins में the question which they ask you is, see, please remember, conjoint twins, they are variety of monochorionic monoamniotic twins. So conjoint twins, maybe you have to do a cesarean section between 32 to 34 weeks. Most common variety of conjoint twins is paraphagus variety, जिसमें the buttocks and the lower part of the body are fused. Second most common variety is thoracophagous. Then least common variety of conjoined twins is rachiphagus, in which the vertebral column is fused. And if that is not given, then the answer is craniophagus. If they ask you twins may, what is the indication for cesarean? So if it is monochorionic, monoamniotic twin, or if it is a conjoined twin, or if first twin is breech or transverse lie, these are indications for doing cesarean section. Now, whenever you are doing vaginal delivery in a twin, please do not give injection methyl ergometrin after the delivery of first twin. Do not give injection methyl ergometrin. Number 2, if first twin is vertex and second twin is transverse lie, then for the second twin transverse lie, you have to do internal podalic version. Internal podalic version is done in OT. It is done under general anesthesia. You are going to take your hand inside. You are going to hold the baby by its leg and make it breech. Because you are making it breech, it is called as internal podalic version. What is the risk of internal podalic version? Because you are taking your hand inside the uterus and you are bringing the baby's leg out. So that is why there is a risk of uterine rupture. Please remember, internal podalic version is contraindicated in previous cesarean section patients. Right? So the only indication for internal podalic version is if second twin is transverse lie. Now someone is asking me, when is termination of pregnancy done in conjoined twins? Please remember, conjoined twin is a complication or it is a variety of monochorionic monoamniotic twins. Right? तो जैसे monochorionic monoamniotic twins में cesarean करते हैं between 32 to 34 weeks, similarly in conjoined twins you have to do a cesarean section between 32 to 34 weeks. Clear? Okay. Now suppose your question says that there is a female who has previous history of cesarean section, LSCS was done due to fetal distress, and now in this pregnancy she has twins. Can you go for VBAC or 2 lakh? Yes, you can attempt vaginal delivery. So if there is previous history of cesarean section and in present pregnancy there is twins, then vaginal delivery can be attempted. 2 lakh stands for trial of labor after cesarean section. Right? So coming to what are the contraindications for 2 lakh or VBAC? What is VBAC? Vaginal birth after cesarean. 2 lakh is trial of labor after cesarean. It is one and the same thing. So if any female has previous history of classical cesarean section or a T-shaped incision, that is a contraindication. If there is history of uterine rupture, that is a contraindication. If there is history of a uterine scar, you had done any uterine surgery of complete, which had entered into the uterine cavity, complete thickness of the uterus was involved. So suppose myomectomy was done. Myomectomy mein you are entering into the uterine cavity. So history of a uterine scar of complete thickness. Right? That is a contraindication for contraindication for vaginal delivery. These are absolute contraindications for vaginal delivery. Then relative contraindications are if there is previous to LSCS in the past. So if the lower segment cesarean section twice, now third time patient has come to you, so it is a relative contraindication for vaginal delivery. If in present pregnancy there is breech, then that is a contraindication. If in present pregnancy there is macrosomia, these are contraindications for vaginal delivery after cesarean section. Please remember, in present pregnancy, if there is twins, it is not a contraindication. In present pregnancy, if there is PIH, it is not a contraindication. Now, if you are doing vaginal delivery in a patient of previous cesarean section, is induction of labor contraindicated? No. Induction of labor is not contraindicated in previous cesarean section patients, but prostaglandins are contraindicated. I am going to induce labor by mechanical methods. right? Mechanical methods like Foley's catheter. Whenever my patient is undergoing vaginal delivery, and it is a vaginal delivery after cesarean section, it is very important that I maintain a partogram and I keep on checking the scar integrity after every 30 minutes. ये जो scar हमें check करना है, ये uterine scar check करना है, skin का scar नहीं check करना है. Uterine scar has to be checked 2 centimeters above the pubic symphysis. So अगर patient का scar rupture होने वाला होगा, there will be a lot of uterine tenderness, right? So whenever you are doing vaginal delivery after cesarean section, check for scar integrity after every 30 minutes, right? Now if your question says that there was a case of previous cesarean section, right? If your question says that in a case of previous cesarean section, all of a sudden the contractions stop and the contractions are no longer felt, right? And fetal parts can be felt perabdominally. Ab contractions feel nahi ho rahe perabdominally, but fetal parts are being felt. Free fluid is present in the peritoneum. Fetal heart sounds are absent, and on per vaginal examination there is loss of fetal station. Loss of fetal station ka matlab hai now I cannot identify any fetal station. This means they are talking about uterine rupture. Fetal parts jab bhi hame acha, sometimes they say that there is a break in the contour of uterine wall. So again that means they are talking about uterine rupture. अब अगर uterus rupture हो गया है तो fetus is dead. Now the management is you have to resuscitate the mother, you have to do laparotomy, and you have to repair the uterus. अगर uterus repair हो सकता है repair करोगे. If it cannot be repaired, you are going to go for hysterectomy, right? So this is how you identify uterine rupture in your clinical questions. This was a question which came in FMGE and I thought I should share it with you. This is about obstetrical audit. Obstetrical audit includes is done in all except. So when do you do obstetrical audit? See, remember, auditing हम तब करते हैं whenever I have to report maternal death, infant death, or in case of severe morbidities. Right? So like if there is maternal miss, right? So if patient was about to die, there was a case of severe morbidity, then in that case we are going to do obstetrical audit, right? So fetal death के case में audit करेंगे. मॉर्बिडिटीज लाइक ब्लैडर की इंजरी हुई है करेंगे, फीटल हेड की इंजरी हुई है करेंगे. प्री टर्म लेबर में वी डू नॉट डू दी ऑब्स्टेट्रिकल ऑडिट, राइट? Now, some important algorithms which you should know. So, in some important algorithms, you should know management of shoulder dystocia. Shoulder dystocia is inability to deliver the shoulder even after 1 minute of delivery of the head. And in shoulder dystocia, you have to manage it in this same manner in which I am telling you, helper, where H stands for call for help, E stands for give a liberal episiotomy, L stands for you are going to do the leg maneuver, which is mcRoberts maneuver, where you are going to hyperflex the thighs of the female. Then you are going to do P, that is you are going to give suprapubic pressure and again perform mcRoberts maneuver. This is called as Rubin 1. Please remember, suprapubic pressure is given in shoulder dystocia, but fundal pressure is contraindicated. Now, if this also fails, then you are going to go to enter maneuvers. You are going to take your hand inside and you are going to rotate the baby. This is called as Wood's corkscrew maneuver or Rubin 2 maneuver, right? If this also fails, then you are going to take your hand inside and forcefully deliver the posterior arm of the baby, which is called as Jack Mayer's maneuver. If this also fails to deliver the shoulder, then you ask the mother to roll on all 4 limbs. So mother will lie on her all 4 limbs, which is called as Gaskin's maneuver. And if that also fails, then the last step which you have to do is you have to put the head of the baby inside and do a cesarean section, which is Zavanelli's maneuver, right? In dead babies, clidotomy can be done. That means you can fracture the clavicle of the brain. There is a clavicle of the baby. There is no role of symphysiotomy, right? So HELPERR, helper. This is the sequence. Each and every maneuver, each of these maneuver has to be tried maximum for 30 seconds, and 30 seconds mein agar shoulder deliver nahi hua to you go to the next step. Most common fetal complication of shoulder dystocia is Erb's palsy, which involves C5 C6 nerve roots, and most common maternal complication is PPH. Now, what is the algorithm management for atonic PPH? Now, this algorithm I have already discussed with you when I was doing PYQs, right? When I was doing the session on PYQs, I have told you how to manage PPH. This entire algorithm and the dosages of the drugs also I have discussed with you there. So please do from there. PPH ka management is very important, and you have to remember the sequence in which you manage PPH. Then, infections in pregnancy. Infections in pregnancy pe if you get a question, so there are certain catch points which you have to remember. कभी भी कोई infection दिया है and they say that that infection leads to heart disease in the fetus. So there is only one infection which leads to heart disease in the fetus, and that is rubella, right? So that means it is talking about rubella. So any infection leading to heart disease in the fetus is rubella. Rubella is the most teratogenic infection. It leads to congenital rubella syndrome. Congenital rubella syndrome will be seen at less than 20 weeks if mother is acquiring rubella infection. In congenital rubella syndrome, your baby is going to have cataract, sensory neural hearing loss, and congenital heart disease. The congenital heart disease which is seen with rubella is patent ductus arteriosus and pulmonary stenosis. Now, if mother acquires rubella before 20 weeks of pregnancy, then the management is termination of pregnancy. Now, any female who's not vaccinated for rubella and she is not pregnant just now, rubella vaccine is contraindicated in pregnancy. But to all non-pregnant females, you can give rubella vaccine, and whenever you give rubella vaccine, pregnancy is contraindicated for 1 month. So pregnancy is contraindicated for 1 month, right, after giving rubella vaccine. But suppose if there is a patient female who gets pregnant in that 1 month, then there is no need for doing MTP. Congenital rubella syndrome is an indication for doing MTP, but अगर आपने patient को किसी भी female को rubella vaccine दिया and you tell her that she doesn't have to become pregnant for 1 week, right? But in that for 1 month, sorry, and in that 1 month, ek to please stop writing, making these fires. As I told you, my attention gets distracted, and then you will learn all wrong things from me. So instead of saying 1 month, I was telling you 1 week. So if in that 1 month, if mother gets pregnant, if a female gets pregnant, then that doesn't mean that you have to terminate her pregnancy, right? But please remember, rubella vaccine is contraindicated in pregnancy. This is what you have to remember about rubella, right? Now, other infections. Ab other infections mein history dekho. If question is giving you history of eating raw or undercooked meat, or if history is saying that there has been contact with cat feces, then that means they are talking about toxoplasma. In toxoplasma, maximum transmission of toxoplasma occurs in 3rd trimester. Most severe toxoplasma infection happens in 1st trimester. In toxoplasma, you get a triad of intracerebral calcification, chorioretinitis, and hydrocephalus. Clear? Now, A similar picture you get with cytomegalovirus. Cytomegalovirus, maybe you get chorioretinitis. Cytomegalovirus, maybe you get calcification, but that calcification is periventricular calcification. And in cytomegalovirus infection, instead of hydrocephalus, you get microcephaly. In case of cytomegalovirus infection, question is going to say that mother had contact with toddlers. So either she is in a crèche, right, or she is a nursery teacher, right? So she will have a contact with toddlers. Then so cytomegalovirus में chorioretinitis, cytomegalovirus में calcification which is periventricular, and cytomegalovirus में there is going to be microcephaly. Now microcephaly अगर आ रहा है question में तो याद रखना microcephaly can happen because of Zika virus also. Zika virus is the only teratogen which is insect-borne teratogen. It is spread by Aedes mosquito. The receptors which are needed for acquiring Zika virus is TIM1 receptor and TAM-AXL receptors, right? ये जो Zika virus होता है, because it has affinity for TIM1 receptors and TAM-AXL receptors, and these receptors are present in the half-bare cells of placenta. That is why Zika virus has vertical transmission also. जब Zika virus vertically transmit होगा, and this happened long time back in Brazil, there was a Zika virus epidemic which had happened. All babies which were born had microcephaly. There was intracranial calcification. There was increased tone of the limbs, and they had club foot. Right? So there was club foot, microcephaly, intracranial calcifications, and the tone of the limbs was increased. These are the features which you get with Zika virus. अब As I told you, microcephaly आएगा तो cytomegalovirus भी सोच सकते हो, microcephaly आएगा तो Zika virus भी सोच सकते हो. Similarly, whenever they say limb में problems हो रही है, अब limb में अगर problem हो रही है, then you can think about Zika virus, and you can also think about varicella zoster, that is chicken pox, right? Now chicken pox का या varicella zoster का जो maximum teratogenic period होता है, that is 12 to 20 weeks, and if mother acquires infection between 12 to 20 weeks, it leads to congenital varicella syndrome. Congenital varicella syndrome में again there is going to be microcephaly. Congenital varicella syndrome में image दिखाएंगे baby की with limb contractures, with limb deformities and cicatricial skin lesions. So कहीं पर भी if you are hearing these words that there are cicatricial skin lesions, there are limb contractures, microcephaly, then that means it is varicella zoster infection, right? Congenital varicella zoster infection. Neonatal varicella zoster infection is seen if mother gets chicken pox 5 days before delivery or 2 days after delivery. Neonatal varicella syndrome में baby is going to have pneumonia, hepatitis and meningoencephalitis, right? Then, now if your question says that in fetus there is hydrops fetalis, there is anemia, in mother there was polyhydramnios, and when the baby was born we were seeing some skin rashes which is like a slabbed cheek appearance. So mother में भी मिल सकती है slabbed cheek appearance, right? Then it means which infection they are talking about? Which infection are they talking about? Quickly tell me in the chat box. बेबी में हाइड्रोकेफल, फीटस में हाइड्रोकेफलस है, अनीमिया है, मदर में पॉलीहाइड्रामनियोस है, यू आर गेटिंग अ स्लैब्ड चीक अपीयरेंस, or you are getting reticular rash on the trunk. This means it is parvovirus B19 infection, right? So this is what you have to remember about infections in pregnancy, right? Then comes quickly about partogram, labor care guide. This is the new partogram which has come, which is based on WHO's new guidelines, right? And according to WHO's new guidelines, active phase begins at 5 centimeters, and that is why plotting in labor care guide begins at 5 centimeters. In a labor care guide, there is focus on individualizing intrapartum care. There is no action line, there is no alert line. Now, other thing is कि अभी तक जो हम partogram use करते थे, which was a modified WHO partogram. In modified WHO partogram, we had action line, we had alert line. In modified WHO partogram, active phase began at 4 centimeters. So plotting began at 4 centimeters. In modified WHO partogram, second stage of labor was not represented. Monitoring of second stage of labor was not done. But in labor care guide, monitoring of second stage of labor is done. Then in labor care guide, whenever a female starts pushing, we write the word P there. Then in labor care guide, there is a new section which is called as supportive section. इस supportive section में we are going to write down what are the drugs we have given for pain relief, what are the drugs we are giving for how much oral fluid we are giving to the mother, what posture delivery was conducted, and who was the companion. So these are 4 things which we are going to include in labor care guide. Then in WHO's modified partogram हम uterine contractions बताते थे, plus हम strength को भी mention करते थे. In labor care guide, we are going to tell only about the duration and about the frequency. So that reminds me कि modified WHO partogram में you are going to tell me uterine contractions को कैसे represent करते थे. So there were boxes which were squares which were present, and you had to color those squares. So number of squares which you color, right, in 10 minutes, that represented the number of contractions in 10 minutes. So uterine contractions were measured after every 30 minutes, and for after every 30 minutes we used to see how many contractions are happening in 10 minutes, and utne squares ko hum color kar dete the. Now if we made dots, that means the contraction lasted for less than 20 seconds. If we made oblique lines, that means contraction lasted for 20 to 40 seconds. And if we colored it in a solid manner, that means contraction lasted for more than 40 seconds. Clear to all of you? Now, a few questions which I have included in Marrow also, and I teach in my classes also. I am just sharing with you them with you over here. All of the following are true regarding partogram except right side of alert line indicates referral to FRU. As I told you कि जो modified WHO partogram था, in modified WHO partogram there were 2 lines, action line, alert line and action line. The time difference between these 2 lines was 4 hours. Now if your patient's progress lied towards the left of alert line, that means it is normal. If your patient's progress lied between alert and action line, that means you have to get alerted and you have to send the patient to a higher center if needed. And if your patient's progress lied to the right of action line, that means now some action has to be taken. So over here they are saying right side of alert line indicates FRU, that means referral, yes. There is a 4 hours difference between alert line and action line, yes. Each square in a partogram is 30 minutes, no. Each big square in a partogram is 1 hour. Partogram is plotted once the cervical dilatation reaches 4 centimeters. Yes, this is because this partogram which they are talking about is a modified WHO partogram, and modified WHO partogram ke according active phase began at 4 centimeters. Right, so plotting began at 4 centimeters. But suppose you get a question that there is labor care guide. So a midwife at PHC is monitoring pregnancy and she is maintaining labor care guide of pregnancy progression. At how much dilatation should partogram plotting be started? So labor care guide को हम कितने time पे start करते हैं? Labor care guide is started at 5 centimeters, right? पुराना जो partogram था that was modified WHO partogram and वहां पे plotting began at 4 centimeters. Clear to all of you? Now the next question which was there, when a patient in labor presents to us for the first time, where on partogram will you plot the dilatation? So when a patient comes to you for the first time, please remember the first marking should be done on the alert line. But if on the alert line is not given to you, then you are going to say towards the left of alert line. Best answer for this question is on the alert line. But if that is not given, then to the left of alert line. Right? Then, a 38 weeks primigravida presented to the labor room with minimal labor pains and contraction. On examination, cervix is 2 centimeters dilated, 50% effaced. Heart rate normal hai, BP normal hai. What should be done? 2 centimeters का मतलब है patient is in latent phase. अब अगर patient latent phase में है, right, so already labor start हो चुका है, so there is no role of inducing labor, and especially there is no role of ARM, artificial rupture of membranes, and oxytocin. These are methods which are done in active phase. Whenever there is a protracted active phase का मतलब active phase is going very slowly. Protracted active phase. So in protracted active phase, management is ARM and management is oxytocin. But यहाँ पे patient latent phase में है. Latent phase में there is no role of oxytocin, no role of ARM. Then sedate the patient. Now, why do I want to sedate the patient? Sedate the patient answer होता है whenever it is a case of prolonged latent phase. Now, this is not a case of prolonged latent phase. So, you are not going to sedate the patient. Simply, you have to observe the patient and you have to wait for increase in uterine contractions. Right? So, all this we have done. Contraindications to breastfeeding we have done. Just quickly, I want you to know what are postpartum blues, postpartum depression, and postpartum psychosis. Postpartum blue is more common, and postpartum blue mein patient will have mild insomnia, irritability, fatigue. She might cry, and this happens between 2 to 4 days postpartum, and it resolves within 10 days after delivery. No treatment is needed for postpartum blues. Postpartum depression is seen in 10% patients. It is seen between 2 weeks to 12 months postpartum. Patient will have phobias, she will have anxieties. Her symptoms are going to worsen more in the evening time. And in postpartum psychosis, which happens again 2 to 3 days postpartum, and there is no time, it will never resolve on its own. Patient will behave in a very, she will have clouded sensorium, she will be confused, there will be attention deficit, then that is postpartum psychosis, right? Most common amongst them is postpartum blues. Thankfully, our OBS is over, and in gynae, I just have to tell you 4-5 things which are very important. So, you want me to continue gynae now? Do you want me to continue gynae or you want me to take it up some other day? OBS is done. Whatever I wanted to tell you in OBS, that is over. 21st is your session for 21st, I think, is your session for image based session. So what I'm going to do is I will take your gynae quick revision on 20th. Is it okay with all of you? Right? So if we do on 20th Feb, if we do, what are you saying? Yes का मतलब continue करना है या yes का मतलब you want me to do it on 20th? Continue. Okay. Just 2 minutes. Let me have some water. I am continuing. Don't worry, I am continuing. I'm just having water and we are continuing with gynae. Okay. gynae में see, in gynae, one very important thing which you have to revise quickly is management of vulval cancer. Right? So management of vulval cancer में I'm giving you a flow chart. Just if you revise this much for management of vulval cancer, that will be fine. In management of a batch from Hyderabad missed ovarian and endometrial cancers. Oh, okay. So if you have missed ovarian and endometrial cancer, let me connect to the Hyderabad team and maybe I take your endometrial cancer. Definitely I have to teach you full. Ovarian cancer is a very theoretical topic, but endometrial cancer I am going to teach you. So let me talk to them, and if through a webinar I can connect with you, I will take your complete endometrial cancer. Don't worry. Thank you for reminding me. Which was the batch which had missed endometrial cancer? Just mention it there. Okay. Now coming to vulval cancer may, whenever you are getting management of vulval cancer, you have to see the stage, and based on the stage we are going to do the management. Now stage of staging वैसे vulval cancer की नहीं याद करनी है. Just for the management purpose we have to remember that stage 3 and stage 4 may management is chemo radiation. And how do we come to know that it is stage 3 or stage 4? Because in stage 3 or stage 4 lymph nodes are involved. In stage 1 and stage 2 lymph nodes are not involved. So if lymph nodes are involved in vulval cancer, and that means either it belongs to stage 3 or it belongs to stage 4. And whenever vulval cancer belongs to stage 3 or stage 4, management is chemo radiation. Now when lymph nodes are not involved, either it means it is stage 1 or it is stage 2. अब stage 1 में we have 1A. 1A का मतलब होता है that the size of the tumor is less than equal to 2 centimeters and the depth is less than equal to 1 millimeter. Stage 1A का मतलब है size of the tumor less than equal to 2 centimeters, depth of invasion is less than equal to 1 millimeter. Stage 1 and stage 2 में management is surgery. Stage 3 and stage 4 में management was chemo radiation. Stage 1 and stage 2 में कभी भी lymph nodes involved नहीं होंगे. Stage 3 and stage 4 the lymph nodes are involved. Now in stage 1, 1A means that the size of the tumor is less than equal to 2 centimeters and depth of invasion is less than equal to 1 millimeters. So the surgery which I am going to do in them will be a vulvectomy. In your options, it can be given as partial radical vulvectomy or a total radical vulvectomy. Right? And there is no need for any lymph node dissection if it is stage 1A. Then comes stage 1B. Stage 1B means either the tumor is more than 2 centimeters in size or the tumor's depth is more than 1 millimeter. The depth of invasion is more than 1 millimeter. Now, if it is stage 1B, again the surgery is vulvectomy, radical vulvectomy or a partial vulvectomy, and simultaneously you will have to do a lymph node dissection, right? Then comes stage 2 vulval cancer. Stage 2 vulval cancer means any size of the tumor which involves lower 1/3 of anus, lower 1/3 of urethra, or lower 1/3 of vagina. So if there is any size of the tumor involving lower 1/3 of vagina, urethra, or anus, you call it as stage 2. Again, in stage 2, I have to do vulvectomy and I have to do lymph node dissection. So in stage 1A, only vulvectomy, no lymph node dissection. 1B and 2, I have to do vulvectomy plus lymph node dissection. Most of the times, the lymph node dissection which you have to do is bilateral inguinofemoral dissection. Bilateral inguinofemoral dissection. There are only few exceptions to this where you can go for a unilateral dissection. So what are the conditions in which I can go for a unilateral dissection? We can go for a unilateral dissection only if all these three conditions are fulfilled. Number one, if the size of the tumor is less than 2 centimeters. Number two, if location of the tumor is more than 2 centimeters from the midline. And number three, if local extension is absent. So if all these three conditions are there, then we go for unilateral inguinofemoral lymph node dissection. So suppose, now you are going to say, ma'am, stage 1B ka matlab hai, you are saying that the size of the tumor is more than 2 centimeters, right? And in 1A, जिसमें size less than 2 centimeters होता है, we never do a lymph node dissection. And now you are saying that unilateral lymph node dissection is done if size is less than 2 centimeters. So ma'am, इसका मतलब तो unilateral lymph node dissection we will never do. Now please understand, 1B means either the size is 2 centimeters or depth of invasion is more than 1 millimeter. So suppose your question comes that there is a tumor which is 1 centimeter, right? And the depth of invasion is 2 millimeter. Now, because depth of invasion is 2 millimeters, you are going to put it in stage 1B. Right? And when you put it in stage 1B, your management becomes vulvectomy plus lymph node dissection. Now, if only this much information is given to you and they ask you whether you are going to do unilateral lymph node dissection or bilateral lymph node dissection, because size of the tumor is 1 centimeter, you will say, I will do a unilateral lymph node dissection. Clear to all of you? So this is how you decide bilateral lymph node dissection or unilateral lymph node dissection. Most of the times bilateral. Only if size of the tumor is less than 2 centimeters, if it is more than 2 centimeters away from midline, or if local extension is absent, then you go for unilateral lymph node dissection. Clear to all of you the management of vulval cancers? Yes. There is no need to mug up the entire staging of vulval cancer. In this flowchart, jitni staging maine bata di, that is important. Other than this, you don't need to mug up the staging for vulval cancer. What does it mean when they say no local extension? So, no local extension means this. Stage 2 disease. Stage 2 disease mein the disease is locally extending to lower 1/3 of vagina, lower 1/3 of urethra, lower 1/3 of anus. Right? That is what is no local extension. 1B का मतलब है no local extension. Yes. Now, next important thing in gynae is they ask you the next step in management. If they say next step in management and they ask you, patient is having post-coital bleeding, what is the next step? Now, whenever they say patient is having post-coital bleeding and they ask you the next step is per speculum examination. Now, if your question says patient is having post-coital bleeding and on per speculum examination, a per speculum examination they have done, on per speculum examination cervix is normal. Now what is the next step? Now next step is pap smear. If they say on per speculum examination growth is seen, so then the next step becomes sponge biopsy. Now, if they say that on per speculum examination cervix is barrel shaped, thick, indurated and firm, then in that case again the next step, because it is pointing towards cancer, so the next step is biopsy plus endocervical curettage, right? So colposcopic colpobiopsy plus endocervical curettage, right? Whether you say colposcopy or whether you say colpobiopsy, it's one and the same thing. Clear to all of you? So this is the next step whenever a patient comes to you with post-coital bleeding. Now next step, if they give you some pap smear report and they ask you what is the next step. Please remember, based on pap smear report, we never go for management of CIN. Based on pap smear report, the next step is always biopsy. Right? Yep, next step is some other investigation, but you don't go for I'm going to do hysterectomy or I'm going to manage a CIN based on pap smear report, because pap smear is only a screening test. So if they say that, so I will not write management here because otherwise you get confused. I will write next step. Now, if they say on pap smear you are getting ASCUS, what is ASCUS? Atypical squamous cells of unknown significance. And they ask you what is the next step. So this means the histopathologist or the cytologist is telling you that there are some atypical squamous cells, but I don't know their significance. In that case, if age of the patient is less than 25 years, you will repeat a pap smear after 1 year. Repeat a pap smear after 1 year. But if age of the patient is more than equal to 25 years, then you do HPV DNA testing. And if HPV DNA testing is done after an abnormal pap smear report, it is called as reflex HPV DNA testing. Now, if report comes as LSIL, low squamous intraepithelial lesions, and if age of the patient is less than 25 years, next step is again pap smear. This pap smear should be done between 6 months to 1 year. If age of the patient is more than equal to 25 years, then in that case, colposcopy. Right? They can write colposcopy, they can write colposcopic guided biopsy, they can write colpobiopsy, all of them mean the same thing. Now, if report is HSIL, HSIL means high squamous intraepithelial lesion, then in all age groups, no matter what is the age group, the next step is colposcopy plus endocervical curettage. Similarly, if the report is ASCH, what is ASCH? Atypical squamous cells where HSIL cannot be ruled out. Now, wherever you get this word H, the next step is, that means it has high chances for cancers or it has high chances for CIN2 and CIN3. So the next step becomes colposcopy and endocervical curettage. If report comes as AGUS, atypical glandular cells of unknown significance. Now, these glandular cells could come from endometrium. So, it can be an endometrial cancer which has spread to cervix, or it could be a cancer of endocervix. So in this case, I'm going to do colposcopy. In this case, I'm going to do endocervical curettage, and I am going to do endometrial biopsy. All these three have to be done if it is a case of atypical glandular cells of unknown significance. About HPV vaccination, you should know what are the WHO SAGE guidelines. The WHO SAGE guidelines say that if the age of the patient is between 9 to 14 years, then you have to give one dose of HPV vaccine. If age group is between 15 to 20 years, then either one or two doses. And if age of the patient is more than equal to 21 years, then you have to give two doses 6 months apart. Please remember the age group is 9 to 26 years for giving HPV vaccine, but in high risk patients you can give from 27 to 45 years. Ideally, HPV vaccine should be given before a female starts her sexual activity, but then it can be given even after she has started her sexual activity. HPV testing is not needed before giving this vaccine, and screening should not be stopped after giving HPV vaccine. If a patient is HIV positive, then the doses which you have to give are 3 doses. So this is WHO SAGE guidelines for giving HPV vaccine. According to WHO, in a resource limited country like India, the best screening test for cancer cervix is HPV plus VIA. Right? If HPV plus VIA is not given in the options, then the second best is HPV DNA testing. And if that is also not given, then VIA. VIA is visual inspection with acetic acid. According to WHO, in India, screening should begin at 30 years and it should end at 49 years. Right? Now, next step. Next step, if a patient comes to you with postmenopausal bleeding. If a patient comes to me with postmenopausal bleeding, then next step is I am going to do a TVS. On TVS, if endometrial thickness, I am going to measure the endometrial thickness. If endometrial thickness is less than 4 millimeters and my patient is having postmenopausal bleeding, that means her bleeding is happening due to atrophic endometrium, senile endometritis, and so my next step becomes I am going to give her tranexamic acid. ट्रानेक्समिक एसिड देने के बाद भी if the bleeding persists, then my next step is fractional curettage plus hysteroscopy. Right? But I am going to do fractional curettage and hysteroscopy only if the endometrial thickness was less than 4 millimeters. I gave her tranexamic acid but bleeding persisted. Now suppose if endometrial thickness is more than equal to 4 millimeters, in that case my next step is endometrial sampling. This endometrial sampling can be done by endometrial aspiration cytology or it can be done by endometrial biopsy. Anything out of these things, anything can be written. राइट अब ये जो हम एंडोमेट्रियल सैम्पलिंग करते हैं एंड नाउ सैम्पलिंग का एंडोमेट्रियल बायोप्सी का रिपोर्ट आता है एंड द रिपोर्ट सेज atypia is present. That means atypical cells are present. There is endometrial hyperplasia with atypical cells. So if atypical cells are present, that means there is a high possibility of endometrial cancer, and before I do hysterectomy in them, I should see कि कहीं concurrent endometrial cancer तो नहीं है. And to rule out concurrent endometrial cancer, again I will do fractional hysteroscopy, fractional curettage plus hysteroscopy. So whenever there is endometrial hyperplasia with atypia and they ask you next step, do not jump to hysterectomy. Next step is fractional curettage plus hysteroscopy to rule out कि कहीं endometrial cancer already present तो नहीं है. Because if endometrial cancer is already present, I will not just do hysterectomy, right? If after doing fractional curettage and hysteroscopy, I know no endometrial cancer is present and they ask me what is the best management, then best management is hysterectomy. Now someone is asking me what is the difference between endometrial sampling, endometrial aspiration curettage, endometrial biopsy. No difference. For you people, just remember out of these three, anything could be written and all three are right. Clear? Now, if endometrial biopsy report says atypia is not present, then what is the next step? Then the next step is you give progesterone. You give her progesterone. But if bleeding persists in spite of giving progesterone, now I am worried that why there is bleeding in spite of giving progesterone. So now I will do fractional curettage plus hysteroscopy. This means if someone asks you what is the investigation of choice for any endometrial lesion, the investigation of choice for endometrial pathology is endometrial biopsy, but the gold standard is fractional curettage plus hysteroscopy. Right? So these are all next steps which you have to remember. Very, very important next steps. Right? Then just one more thing which I want to revise with you. In case of gynae. So in gynae, whenever they say a patient is having primary amenorrhea, right? Primary amenorrhea and uterus is absent. Now, in this case, there are two differential diagnoses which you have to keep in mind. Number one, you have to keep in mind MRKH, that is Mullerian agenesis. And number two, which you have to keep in mind is androgen insensitivity syndrome. Both of them, in here the chromosome number is 46XX, here it is 46XY. Here the gonads are ovaries, here the gonads are testes. In case of Mullerian agenesis, breast development will be stage 4 plus. Here also breast development will be stage 4 plus. But in Mullerian agenesis, pubic hair and axillary hair will also be they will be well developed stage 4 plus. But in case of androgen insensitivity, pubic hair and axillary hair, they will be stage 1 or stage 2, right? In case of Mullerian agenesis, testosterone levels will be normal like a female level. In case of androgen insensitivity, testosterone levels will be very, very high. In case of Mullerian agenesis, LH levels will be normal, FSH levels will be normal. In case of androgen insensitivity, FSH levels will be normal, LH levels will be very high. Right? Because they are insensitive to testosterone. So the negative feedback on LH is gone. So the levels of LH will increase. And because inhibin is secreted by Sertoli cells, inhibin is going to keep FSH under control. Right? So this is the reason why, FSH is normal, LH levels are high. Now here you are going to get renal anomalies. Here there will be no renal anomalies. So this is how you differentiate between MRKH and androgen insensitivity syndrome. Now if you get a question which says that there is primary amenorrhea and uterus is present, In this case, the differential diagnosis could be Turner's syndrome. Differential diagnosis could be Swyer's syndrome. Differential diagnosis could be Kalman syndrome, and it could be cryptomenorrhea. Now, in all these cases, the first thing which you should note is FSH levels and LH levels. Now, LH and FSH levels will be high in Turner syndrome. Here, the chromosome number is 45XO. So, they have got a streak gonads, and because they have streak gonads, the estrogen is not there. So, the negative feedback on LH and FSH is gone. In case of Swyer's syndrome, again FSH and LH levels are high. They are 46XY, individuals who have dysgenetic testes, right? In Kalman syndrome, the levels of LH and FSH will be decreased because they have got decreased GnRH. The problem is hypothalamic failure. In case of cryptomenorrhea, the levels of LH and FSH are going to be normal. So based on LH and FSH levels, you can come to know that which of these problems it is. Another thing, in case of Turner's syndrome, you will have short stature. The patient will have short stature. Stature will be normal in Kalman syndrome, in cryptomenorrhea, and in Swyer's syndrome, right? In Swyer's syndrome, the uterus is present. So in all these conditions, uterus is present. In case of Turner's syndrome, Swyer's syndrome, and Kalman syndrome, because estrogen is decreased, that is why breast development is absent. In Swyer's syndrome also, there is no testosterone because of dysgenetic testes. So there is no estrogen. So again, breast development is absent. In Kalman syndrome, because there is decreased GnRH, decreased LH, decreased FSH, so again breast development is absent. But in cryptomenorrhea, breast will be present and it will be fully developed, normal breast development, right? Now, in Turner's syndrome, the other thing which you have to remember is you will get associated findings like webbing of neck, like there will be cubitus valgus, like there is going to be low posterior hairline, shield shaped chest, right? So you are going to get associated findings. In case of Kalman syndrome, there will be anosmia, right? So based on these findings, you can come to know what is the problem in your patient. So that is how you diagnose a patient with primary amenorrhea. Clear to all of you? Have you understood how to diagnose in your questions a case of primary amenorrhea? Now, coming to secondary amenorrhea. If you get a question on secondary amenorrhea and your question says that the levels of FSH are increased, then it means they are talking about premature menopause. The other name or the new name for premature menopause is primary ovarian insufficiency. Because ovaries are not functioning, so there is decreased estrogen. That is why the FSH levels are increased. Now, if your question says FSH levels are normal or they are low, right? Then what you have to see in your question, what have they told you about progesterone withdrawal test, right? If bleeding is present after progesterone withdrawal test, that means progesterone withdrawal test is positive, then they are talking about PCOS. Please remember, in PCOS, levels of FSH are normal. It is only the levels of LH which is increased, right? Now, If bleeding is absent, that means progesterone withdrawal test is negative. In that case, you check the levels of estrogen. If levels of estrogen are normal, then it means it is a case of Asherman syndrome. Right? If they say estrogen is decreased, then it means either the problem is in hypothalamus or problem is in pituitary. Problem in pituitary could be Sheehan syndrome or it could be a prolactinoma. Right? Now, how am I going to come to know whether it is hypothalamus problem or pituitary problem? I will do an MRI. If on MRI, I am getting empty sella turcica, it means it is Sheehan. If I am getting a space occupying mass, it means it is prolactinoma. And if MRI is normal, it is problem in hypothalamus. Clear? So this secondary amenorrhea ka flowchart, please memorize this properly. Secondary amenorrhea में only one condition में FSH is raised, that is premature menopause. FSH normal है या low है, तो look at progesterone withdrawal test की report. If your question says progesterone withdrawal test is positive, what does that mean? कि progesterone देने के बाद bleeding हो गई. That means it is a case of PCOS. If bleeding is not present after giving progesterone, then look at the levels of estrogen. Estrogen के levels normal है, it means it is Asherman syndrome. That means uterus में intrauterine additions are present. And if estrogen levels are decreased, या तो problem hypothalamus में है या problem pituitary में है. Pituitary में problem could be Sheehan या prolactinoma. And hypothalamus में problem could be stress, overexercise, or it could be anxiety. All that can lead to secondary amenorrhea. To differentiate between them, you are going to do an MRI. MRI में empty sella turcica है तो Sheehan, space occupying mass है तो prolactinoma. Everything is normal, then it is hypothalamus. Clear to all of you? Please remember, in case of Sheehan, patient comes to you with complaint of failure of lactation plus secondary amenorrhea. Right? And they can be features of other hormone deficiencies as well. In prolactinoma, patient comes to you with complaint of secondary amenorrhea, infertility, and there is increased milk. So there is galactoria. Galactoria along with headache and visual disturbances. Right? Why is prolactinoma causing secondary amenorrhea? Because in prolactin has a negative feedback on GnRH, so it leads to amenorrhea. Prolactin leads to milk secretion, so it is leading to galactoria. Because prolactin is a pituitary tumor, it is very near to optic chiasma, so it is leading to visual disturbances and headache. Clear to all of you? So that's all what you need. I mean, you need to know more, but this is, if you do this much along with PYQ session, along with image based session, I think this should solve your purpose. So all the best to all of you. Keep studying, and that with this, I'm going to conclude today's session. Take care, all of you.